Good evening. Tonight, we wade into the gritty, the uncertain, and the not-so-glorious side of history. Behind the grand tales of knights and crusades lies a far harsher reality, one that tasted of bitter wine and sweet poison. To live it honestly was exhausting. It was a battle fought not on a field, but inside the mind, inside the body, where consciousness itself became the enemy. So before you get comfortable, take a moment to like this video and subscribe, but only if you genuinely enjoy what I do here. And let me know in the comments where you're tuning in from and what time it is for you. It's always fascinating to see who's joining us from around the world. Phone face down, volume at a whisper. Let's go in. The knife and the scream. Picture, if you can bear it, a scene from England in the year 1340. The room is dim, lit only by tallow candles that sputter and smoke. The air is thick with the smell of unwashed bodies, blood, and something else, something medicinal and wrong. A man lies on a rough wooden table. He is a soldier, recently returned from the endless wars with France, an arrow wound in his thigh that has festered and turned black at the edges. The stench of rot is unmistakable. The flesh must come off, or the poison will travel through his blood and kill him within days. Around him stand 4 other men. 2 are there simply to hold him down, their calloused hands already positioned at his shoulders and his good leg. The 3rd is the barber surgeon, a man whose trade involves equal parts haircutting and flesh cutting, his leather apron stiff with old blood. In his hand is a saw, its teeth dulled from previous use but still serviceable. The 4th man, standing slightly apart, hold a leather strap folded thick. This will go between the patient's teeth, so that when the agony comes, he does not bite through his own tongue. There is no countdown, no careful administration of gas through a mask, no gentle slide into unconsciousness while a team of masked professionals monitors your vital signs. There is only the saw, the scream, and the desperate hope that it will be over quickly. The barber surgeon works fast. Speed is the only mercy he can offer. He makes a circular cut through the skin and muscle, exposing the bone. The patient's scream is muffled by the leather strap, but his body convulses with such violence that the 2 men struggle to keep him on the table. Then comes the saw. The grinding of metal against bone is a sound that those who hear it never forget. The patient's eyes roll back, his body goes rigid, and for a moment there is hope that he has fainted, that his mind has fled the horror. But no, he remains conscious through it all, feeling every stroke of the blade, every splinter of bone. The whole procedure takes perhaps 90 seconds. It feels like hours. When it is finished, the stump is wrapped in cloth soaked in wine and honey, if they can afford it, or simply in old rags if they cannot. The patient is carried away, gray-faced and shaking, his mind fractured by what he has endured. He will survive, perhaps, or infection will set in, and the fever will take him within a week, or the shock alone will stop his heart before morning. These are the odds. This was surgery in the medieval world. This was the baseline reality for anyone who needed a limb removed, a stone cut from their bladder, or a skull opened to release the pressure of a head wound. Pain was not a side effect of surgery. Pain was surgery, and for centuries, there was no escape from it, except perhaps there was, in certain households, in the pages of carefully guarded manuscript books, in the knowledge passed quietly from mother to daughter, or from monk to monk, there existed a recipe. A drink. A potion that promised something unthinkable. It promised sleep. Not the gentle sleep of a tired man at the end of a long day, but a deep, unnatural sleep. A sleep so profound that a surgeon could cut into flesh, saw through bone, and the patient would not feel it, would not scream, would not remember. They called it DWale. The word itself comes from Old Norse, from dul, meaning sleep or trance. But it meant more than that. It carried with it the weight of something forbidden, something powerful, something that walked the line between healing and harm. DWale was not a medicine you took lightly. It was a gamble, a roll of the dice where the stakes were consciousness, memory, and life itself. The recipe for DWale appears in dozens of medieval English manuscripts, copied and recopied from the 12th century through to the 15th. It was never officially sanctioned by the surgeons themselves, who warned against its use. It was never taught in the medical schools of Oxford or Cambridge. Instead, it lived in the shadows, in the domestic remedy books kept by literate housewives, in the notebooks of monks who ran infirmaries, in the oral traditions of healers who learned their craft not from books, but from bitter experience. And yet, despite its dangers, despite the fact that it killed as often as it cured, DWale persisted. For 4 centuries, it was England's answer to the unbearable question: how do we cut into a living person without driving them mad with pain? Tonight, we will trace the complete history of this extraordinary substance. We will examine what it was made from, how it worked, who used it, and why it eventually disappeared from the medical arsenal. We will meet the ingredients themselves, each one a character in this story, some relatively harmless, others lethally poisonous. We will see DWale through the eyes of the terrified patient, the desperate housewife, the skeptical surgeon, and the modern pharmacologist who has attempted to reverse engineer this medieval concoction in a laboratory. This is not a story of simple progress, of ignorant medieval people stumbling in the dark until the brilliant modern era arrived to save them. This is a story far more complex. It is a story of genuine innovation, of careful observation, of trial and error conducted at enormous human cost. It is a story of people who understood that there were plants that could change consciousness, and who tried desperately to harness that power for good, even when they did not fully understand the mechanisms at work. It is also a story of failure, of the thin line between dose and overdose, of the patients who drank DWale and never woke up, of the memory loss, the madness, the permanent neurological damage that could result even when death was avoided, of the reason why, despite its promise, surgeons themselves refused to use it, and why it eventually faded from history, replaced by more reliable, more controllable substances. But before we can understand DWale, we must first understand the world that created it. We must see the desperate need that drove people to mix deadly poisons into wine and offer it to their loved ones. We must feel the weight of a time when pain was not just expected but inevitable, when surgery was a last resort undertaken only when death was the only alternative. We must go back to a world without anesthesia, to a world where the scream was the soundtrack of healing. The dark ages of surgery, life before anesthesia. If you were born in medieval England, your relationship with pain was fundamentally different from anything we can imagine today. Pain was not a problem to be solved. It was simply a fact of existence, as natural and unavoidable as the weather. You expected it. From the moment of birth, which for both mother and child was an ordeal of unmedicated agony, to the final illness that would eventually take you, pain was your constant companion. But there were gradations. There was the everyday pain of childbirth, of toothache, of broken bones, of disease. This was bad enough. And then there was surgical pain. This was something else entirely. This was pain so intense, so all-consuming, that it could kill you on its own, simply through shock. The medieval surgeon understood this. He had seen men die on the table, not from blood loss or infection, but from a sheer, overwhelming assault on their nervous system. The body, flooded with stress hormones, the heart racing beyond its capacity, simply gave out. This was called dying of the knife, and it was a recognized cause of death, distinct from dying of the wound itself. Consider what it meant to undergo even a relatively simple surgical procedure. Let us take tooth extraction, one of the most common operations. Dental problems were endemic in medieval society. The diet was coarse, full of grit from stone ground flour that wore teeth down in nubs. Sugar was beginning to enter the diet of the wealthy, rotting teeth from the inside. And there were no preventative measures, no fluoride, no regular cleaning beyond the occasional wrinkling with wine or vinegar. When a tooth abscess or cavity became unbearable, you went to the barber surgeon. He sat you in a chair, or more often simply stood you up against a wall for stability. He took a pair of iron pliers, like tongs, their grip rough and uneven. There was no anesthetic. Sometimes you were given wine to drink beforehand, enough to dull your senses, but not enough to render you unconscious. The barber placed the pliers around the tooth and pulled, and pulled, and pulled. Teeth are anchored surprisingly deeply into the jaw. They do not come out easily. The procedure involved not just pulling but rocking, twisting, sometimes breaking the tooth, and then digging out the fragments from the bleeding socket. All of this was done by feel, with you fully conscious and aware of every grinding, scraping, tearing sensation. The pain was described by those who experienced it as white-hot, blinding, a bolt of agony that shot from the jaw up into the skull and seemed to fill the entire head with fire. And this was considered a minor procedure, something routine, something you might undergo multiple times in your life if you lived long enough. Now scale up from tooth extraction to major surgery. Amputation, as we saw in our opening scene, was perhaps the most common serious operation. In a society constantly at war, with weapons that crushed and mangled rather than cut cleanly, with medical understanding of infection still centuries away from germ theory, the only way to save a life from a catastrophically damaged limb was to remove it entirely. The technique was well established. The surgeon would position the patient, usually on a sturdy table. Strong men would hold the patient down at the shoulders, arms, and remaining leg. A tourniquet would be applied above the site of amputation, a rope or leather strap twisted tight with a stick to cut off blood flow. The surgeon would take his knife and make a circular cut through the skin and muscle, down to the bone. Then the saw. The noise alone was traumatic for everyone in the room. The grinding, the scraping, the wet sounds of flesh tearing. And all the while, the patient screamed. The entire operation, if performed by an experienced surgeon, took less than 3 minutes. Speed was everything. The longer it took, the more blood the patient lost, the greater the shock to the system, the lower the chance of survival. Medieval surgeons prided themselves on their speed. It was a dark sort of expertise. But 3 minutes of that kind of pain is an eternity. Studies of modern humans who have experienced extreme pain, even for short periods, show lasting psychological effects. Post-traumatic stress disorder was not named in the medieval period, but the symptoms were well known. Soldiers who had survived amputations often could not speak of it afterward. Some lost their minds entirely. The Italian surgeon Theodoric of Servia, writing in the 13th century, observed that patients subjected to surgical pain without relief frequently die from the pain alone, and many become ill for a long time afterward, their spirits broken. And amputation was not even the worst. Consider lithotomy, the operation to remove bladder stones. These calcified deposits formed in the bladder and, when large enough, caused excruciating pain and an inability to urinate, leading eventually to death by uremia as the toxins built up in the blood. The only solution was surgery. The patient was positioned on his back with his legs pulled up and tied to his neck, completely vulnerable and exposed. An assistant sat on top of him to keep him immobile. The surgeon inserted 2 fingers into the rectum, feeling for the stone through the thin wall of tissue. Once located, the surgeon made an incision in the perineum, the area between the scrotum and anus, cutting down through layers of tissue until he reached the bladder. He then inserted a hook or forceps, fishing around inside the bladder to grasp the stone. If he could get it, he pulled it out. If he could not, he widened the incision and tried again. The pain was indescribable. Many patients died of shock during the procedure. Of those who survived the operation itself, most died within days from infection. The overall survival rate for lithotomy in the medieval period has been estimated at less than 50%, and yet men chose to undergo it, because the alternative, a slow death from urinary poisoning, was even worse. Then there was trepanning, the drilling of a hole into the skull. This was done for a variety of reasons, some more rational than others. Head wounds with depressed skull fractures genuinely require the removal of bone fragments. But trepanning was also performed to release evil spirits in cases of epilepsy, mental illness, or severe headaches. The patient was held down, and the surgeon applied a specialized drill called a trephine, or sometimes simply a knife, to the top of the skull. He worked slowly, carefully, because one slip could drive the blade into the brain itself. The drilling produced a horrific grinding sensation that the patient could feel reverberating through their entire skull. The sound of metal on bone, hollow and raw. And then, if successful, the sudden give as the tool punched through into the cavity beneath. The exposed brain pulsed visibly with a heartbeat, and the slightest touch could cause seizures or death. Archaeological evidence shows that some patients survived trepanning, their skulls showing signs of healing around the hole. But many did not. Cataract surgery, though it sounds delicate, was equally brutal. The procedure, called couching, involved taking a thick, blunt needle and pushing it into the eye through the edge of the cornea. The surgeon then used the needle to physically push the clouded lens backward and downward, out of the line of sight. This was done with the patient fully awake, their head held still by assistants, the needle visible as it entered the eye. The pain was sharp and immediate, and the risk of permanent blindness from infection or damage to the eye was enormous. Even setting broken bones, which we might think of as relatively straightforward, involved significant pain. The limb had to be pulled hard to realign the bones, a process called reduction. Assistants would pull in one direction while the surgeon pulled in the other, the bone grinding as it slipped back into place. For compound fractures, where the bone had broken through the skin, the risk of infection was so high that amputation was often considered the safer option. This was the landscape of medieval surgery, a place where pain was the dominant experience, where the patient's screams were expected, normal, unavoidable. Surgeons learned to work through the noise, to ignore the thrashing, to focus on the speed and accuracy of their cuts. But they were not unaffected. Many wrote of the difficulty, of the emotional toll of inflicting such suffering even in the service of healing. And patients, knowing what awaited them, often delayed surgery until the absolute last moment. They endured infections, gangrene, tumors, bladder stones, until the pain of the condition exceeded even the anticipated pain of the cure. By the time they consented to go under the knife, they were often so weakened that survival was unlikely anyway. This was the problem that DWale sought to solve. Not pain in general, which was too vast a problem, but surgical pain specifically. The pain that came from the knife. The pain that killed. But DWale did not appear out of nowhere. It had ancestors, ancient predecessors that had been trying to solve this same problem for thousands of years. To understand DWale, we must first look backward, to the classical world, to the Mediterranean, to the monks and scholars who kept knowledge alive through the darkest centuries. We must meet the soporific sponge, the grandfather of DWale. The ancient roots, pre-medieval pain relief. The problem of surgical pain is as old as surgery itself. From the moment human beings developed the audacity to cut into living flesh in an attempt to heal, they grappled with the question of how to make it bearable. And they looked, as humans always have, to plants. The ancient world knew pain-relieving plants well. Opium, extracted from the seed pods of the white poppy, was used in Mesopotamia, Egypt, and Greece. Its power to bring sleep and dull pain was recognized thousands of years before anyone understood why it worked. Mandrake, a plant with a thick root that sometimes resembled a human figure, was similarly valued. The Greek physician Dioscorides, writing in the 1st century of the Common Era, described its use as an anesthetic for surgical procedures, including amputations. But the most sophisticated early attempt at surgical anesthesia came not from Greece or Rome, but from the Islamic world of the early Middle Ages. Arabic physicians, who had preserved and built upon the medical knowledge of the ancients while Europe descended into fragmentation and chaos, developed something called the spongia somnifera, the soporific sponge. The recipe is recorded in numerous Arabic medical texts from the 9th and 10th centuries. A sponge was soaked in a mixture of plant extracts including opium, mandrake, henbane, mulberry juice, lettuce, hemlock, and sometimes ivy. The sponge was then dried and stored. When surgery was needed, the sponge would be moistened with water or wine and held under the patient's nose, allowing them to inhale the vapors. The combination of substances would induce a deep sleep, during which the surgery could be performed. The principle was sound. Inhalation allows substances to enter the bloodstream through the lungs rapidly, achieving effects much faster than oral administration. And the combination of drugs, each with sedative or pain-relieving properties, provided a synergistic effect. The opium brought pain relief and euphoria. The mandrake and henbane, both containing tropane alkaloids, induced unconsciousness and a dreamlike state. The hemlock added its own neurotoxic effects, depressing the nervous system. But the soporific sponge was also extraordinarily dangerous. Dosing was nearly impossible to control. How much liquid was absorbed by the sponge? How deeply did the patient inhale? How long before the effects kicked in? There was no standardization, no way to measure, and the substances involved were all, without exception, potentially lethal. The line between an effective dose and a fatal dose was hair-thin. Nevertheless, the technique spread. When the Islamic world began to interact more intensively with Christian Europe through trade, scholarship, and the Crusades, medical knowledge flowed westward. The soporific sponge, along with many other Arabic medical innovations, was translated into Latin. European physicians read with fascination about this technique for rendering patients unconscious. One of the most important translation centers was the Benedictine monastery at Monte Cassino in southern Italy. Here, in the early 9th century, monks worked diligently to translate Arabic medical texts. In one manuscript dated to around 800 AD, a recipe for a soporific concoction appears, listing opium, henbane, mulberry juice, lettuce, hemlock, mandragora, and ivy. This is almost certainly derived from Arabic sources describing the soporific sponge, but adapted for the Italian context. Monte Cassino was not just a center of translation. It was also a center of medical practice. The monastery ran an infirmary and provided care for the sick. Did the monks actually use this recipe? We cannot know for certain, but the fact that they bothered to copy it suggests they found it valuable, at least in theory. From Italy, the knowledge spread northward. Monasteries across Europe maintained herb gardens and infirmaries. They collected medical manuscripts. They experimented with remedies. Monks, who took vows of service and who saw caring for the sick as a holy duty, were deeply interested in anything that could relieve suffering. But something interesting happened as the soporific tradition moved north and west. The climate changed. The Mediterranean herbs, mandrake in particular, did not grow naturally in England, France, or Germany. Mandrake is native to southern Europe and the Middle East. It needs warmth and sun. Attempts to cultivate it in northern Europe were largely unsuccessful, so practitioners had to adapt. They had to find substitutes. For mandrake, they turned to bryony, a native plant of English hedgerows. Bryony's root, like mandrake's, was large and fleshy, and it had been traditionally used as a purgative, a substance to induce vomiting and clear the bowels. It was not, in fact, particularly effective as a sedative. It lacked the tropane alkaloids that made mandrake work. But the resemblance of the root and the tradition of using root vegetables as medicine led practitioners to substitute one for the other. This substitution would become one of the defining features of DWale. The English version of the soporific tradition was not identical to its Mediterranean ancestor. It was an adaptation, a localized variant using whatever plants were available in the damp, cool climate of the British Isles. By the 12th century, as England began to stabilize politically after the Norman conquest, and as literacy slowly spread beyond the monasteries, these recipes began to appear in vernacular manuscripts, not in learned Latin, but in Middle English, the language of the common people. This is significant. It suggests that knowledge of these sleeping drinks was moving outside the exclusive domain of monks and educated physicians. It was becoming, in a limited way, public knowledge. The first clear English references to DWale appear in manuscripts from the late 1100s. The word itself is used, not soporific sponge, which was a Latin and Arabic term, but DWale, a word that would have been immediately recognizable to anyone who spoke the Norse-influenced English of the time. a drink to bring sleep, a drink for those who must go under the knife. These early English recipes varied, but they shared common elements. All included opium. All included henbane, a plant that grew readily in England and whose sedative and hallucinogenic properties were well known. Most included hemlock, despite its reputation as a deadly poison. And most included a variety of other ingredients that seem, from a modern perspective, to be largely inert, such as bile from pigs or goats, lettuce, vinegar, and bryony root. The question modern researchers have asked is, why the harmless ingredients? If opium, henbane, and hemlock were the substances actually doing the work, why all the other things? There are several possible answers. One is tradition. The older Mediterranean recipes included these elements, so the English versions did too, even if no one quite remembered why. Another is the medieval theory of medicine itself. Medieval physicians, working within the framework of humoral theory inherited from the Greeks, believed that medicines worked not just through their direct effects, but through their influence on the body's four humors: blood, phlegm, black bile, and yellow bile. Bile in a remedy was not random. It was thought to help balance the humors. Vinegar was considered cold and dry, which could counteract the hot and wet nature of infection or fever. But there is a third possibility, darker and more pragmatic. Some of the inert ingredients may have been included as deliberate dilution. If you know that the active components of your mixture are deadly poisonous, then adding a significant volume of harmless substances reduces the concentration of the poison. It is a crude form of dose control. You are less likely to kill someone if half the liquid they drink is bile and vinegar rather than pure hemlock extract. Whatever the reason, by the 13th century, DWale had emerged as a distinctly English phenomenon. The name was English. The ingredients were adapted to English plants, and the manuscripts recording it were written in English, not Latin. This was no longer the medicine of the learned elite. This was folk medicine, in the truest sense of the term. Medicine of the people. But what exactly was in DWale? What were these ingredients, and how did they work? To understand that, we need to open the recipe book. We need to examine each component in detail. And we need to understand that some of what we will find is relatively harmless, while other parts are extraordinarily dangerous. We need to make DWale. What was DWale? The recipe and its components. The medieval recipe books are clear on one point. DWale is not a single fixed formula. It is a category of remedies, with dozens of variations recorded across different manuscripts. Some are elaborate, with 10 or more ingredients. Others are simpler, stripped down to just the essentials. But all of them share a common structure. They include a combination of active narcotic and sedative plants, mixed with a variety of other substances that range from the benign to the bizarre. Let us examine a typical example, translated from a 15th century English manuscript. The original is written in Middle English, but rendered into modern language, it reads, "To make a drink that men call DWale, to make a man sleep while men cut him. Take 3 spoonfuls of the gall of a barrow swine, for a woman the gall of a sow, 3 spoonfuls of hemlock juice, 3 spoonfuls of wild lettuce, 3 spoonfuls of opium, 3 spoonfuls of henbane juice, and 3 spoonfuls of vinegar. Also add bryony root, if you have it. Mix them together and put them in a glass vessel. Give him 3 spoonfuls in wine and let him sleep. And when you wish to wake him, dab his temples with vinegar and salt." This is the classic formula. Let's break it down, ingredient by ingredient, and understand what each one brings to the mixture. First, the gall. This refers to bile, the bitter greenish-yellow fluid produced by the liver and stored in the gallbladder. The recipe specifies bile from a castrated male pig, a barrow swine, or from a female pig, a sow. Why the distinction? Medieval medicine was deeply concerned with correspondences and sympathies. Male and female were thought to have different properties, and these properties extended to animals. A barrow, castrated before reaching maturity, was thought to have cooler properties than an intact male, making its bile more suitable for calming remedies. From a modern perspective, bile has no sedative or pain-relieving properties whatsoever. It is simply a digestive fluid, composed of bile salts, cholesterol, and bilirubin. Drinking it would be unpleasant, but not particularly harmful or helpful. Its inclusion in DWale is best understood as a holdover from humoral theory, where bitter substances were thought to have specific therapeutic effects. It may also have served as a liquid medium to mix the other ingredients, and its extremely bitter taste would have been familiar to medieval people as the taste of strong medicine. Next, hemlock juice. Hemlock, properly known as Conia maculatum, is a tall plant with delicate white flowers arranged in umbels, like tiny parasols. It grows throughout Europe, including in England, often in damp places near streams and ditches. And it is one of the most poisonous plants in the world. The toxic compound in hemlock is coniine, an alkaloid that acts as a neurotoxin. It works by blocking the neuromuscular junction, the point where nerve signals are transmitted to muscles. In small doses, it causes weakness and numbness. In moderate doses, it causes paralysis, starting from the extremities and moving inward. In large doses, it paralyzes the respiratory muscles, and the victim dies from asphyxiation, their mind clear until the very end. This is how Socrates died. In 399 BC, condemned to death by the Athenian court, he drank a cup of hemlock extract. According to Plato's account, Socrates remained calm and coherent until the very end, feeling the cold numbness spread from his feet upward, finally reaching his chest and stopping his breath. It was considered a relatively humane form of execution for the time. But why would you include a lethal poison in a medicine meant to help someone? The answer is dose. In very small amounts, the numbing effect of coniine could be useful. It would depress nerve function, reducing sensation. If you were about to have a limb sawed off, even a partial reduction in nerve transmission would be welcome. The problem, of course, is that the therapeutic dose is extremely close to the lethal dose. Medieval herbalists had no way to measure alkaloid content. They simply crushed the plant and used the juice. The amount of coniine varied wildly depending on the plant's age, where it grew, what time of year it was harvested, and how it was prepared. Every dose was a gamble. Then comes wild lettuce. This is Lactuca virosa, or Lactuca serrata, a tall plant with prickly leaves that exudes a milky latex when cut. In small amounts, wild lettuce has mild sedative properties. The latex contains lacticarium, sometimes called lettuce opium, though the comparison is generous. Lacticarium does have weak analgesic and sedative effects, but they are far, far milder than true opium. Modern analysis suggests it may work through similar pathways in the brain, binding to opioid receptors, but with such low efficacy that the effects are barely noticeable. Medieval herbalists, however, believed wild lettuce to be a powerful sleep aid. It was included in many remedies for insomnia and restlessness. In the context of DWale, it was probably one of the safer ingredients. It would contribute to a general feeling of drowsiness and relaxation, but it was unlikely to kill anyone on its own. It may also have added volume and liquid to the mixture, helping to dilute the more dangerous components. Now we come to opium. This is the critical ingredient, the one that provides a genuine pain relief. Opium is the dried latex from the seed pods of Papaver somniferum, the white opium poppy. When the seed pods are still green and unripe, they are scored with a knife. A milky sap oozes out, which is collected and allowed to dry into a dark brownish-black resinous substance. This is opium. Opium contains a complex mixture of alkaloids, but the most important for pain relief is morphine. Morphine works by binding to opioid receptors in the brain and spinal cord, blocking the transmission of pain signals and inducing a state of euphoria and deep relaxation. It is one of the most effective pain relievers ever discovered. Modern hospitals still use morphine derivatives for severe pain. It works, but it also comes with significant risks. Morphine depresses the respiratory system. Too much, and breathing slows then stops. The lethal dose varies widely between individuals. Someone who has never used opiates before might die from a dose that a regular user would find merely pleasant. And medieval practitioners had no way to standardize the opium they used. Was it fresh or old? How much morphine did it actually contain? They simply did not know. What they didn't know was that opium worked. If you gave someone opium, their pain decreased. They became calm. They became sleepy. And if you gave them enough, they became unconscious. The challenge was giving them enough to render them insensible to the knife, but not so much that they stopped breathing. Next is henbane juice. Henbane, Hyacinthus niger, is a plant of the nightshade family, related to deadly nightshade and mandrake. It has a distinctive appearance: large, hairy leaves, a foul smell, and pale yellow flowers veined with purple. It grows readily throughout Europe, including England, often on waste ground and along roadsides. Henbane contains several tropane alkaloids, the most important being hyoscyamine and scopolamine. These alkaloids are anticholinergic, meaning they block the action of acetylcholine, a neurotransmitter critical for many functions, including muscle control, memory, and attention. In small doses, anticholinergics cause drowsiness, confusion, and blurred vision. In moderate doses, they cause vivid hallucinations, delirium, and loss of coordination. In large doses, they cause seizures, coma, and death. But scopolamine has one other property that made it valuable in the context of surgery. It causes amnesia. People under the influence of scopolamine often have no memory of what happened while they were drugged. This was recognized as early as the 19th century, when a combination of morphine and scopolamine was used in obstetrics under the name twilight sleep. Women in labor were given this mixture. They remained semi-conscious, moaning and thrashing, but afterward they reported remembering nothing of the experience. The pain had occurred, but the memory of it had been erased. For medieval surgery, this amnesia effect would have been invaluable if they understood it. Even if DWale did not completely eliminate the pain, even if the patient was partly conscious during the procedure, if they had no memory of it afterward, the psychological trauma would be vastly reduced. They would wake up with the surgery already done, the wound already bandaged, and only a confused sense of lost time. But henbane, like hemlock, was dangerously toxic. The difference between an effective dose and a lethal dose was small, and the alkaloid content varied wildly between plants. A leaf from one plant might be relatively mild. A leaf from the plant growing right next to it might kill you. Finally, vinegar. Acetic acid, the main component of vinegar, has no sedative properties, but it was included for a practical reason. Vinegar was the universal solvent and preservative of the medieval world. It was used to extract medicinal compounds from plants and to preserve foods. In the context of DWale, vinegar would help to extract the alkaloids from the plant materials, dissolving them into the liquid. It also had a reputation as a sharpening agent, something that made other medicines more potent. Interestingly, the recipe also mentions vinegar's use in waking the patient. After the surgery was done, the instructions were to dab the patient's temples with vinegar mixed with salt. This was not just superstition. The sharp, pungent smell of vinegar can stimulate the senses and increase alertness. Smelling salts work on a similar principle. For a patient deeply sedated with DWale, the sudden assault of a vinegar-soaked cloth on the face might help rouse them. Or at least, that was the hope. And then there is bryony root, mentioned as an optional addition, if you have it. Bryonia dioica is a climbing plant with large, fleshy roots. It was used as a purgative, causing violent vomiting and diarrhea, which were thought to clear the body of toxins. Its inclusion in DWale is puzzling until you understand that it was meant to be a substitute for mandrake. Mandrake, the Mediterranean wonder drug, did not grow in England, but bryony did. And because bryony's root was large and somewhat human-shaped, like mandrake's root, medieval herbalists seem to have reason that it would work similarly. This is an example of the doctrine of signatures, the belief that the physical appearance of a plant indicated its medical use. A root shaped like a human would cure human ailments. But bryony lacks the tropane alkaloids that make mandrake effective. Its inclusion in DWale probably did very little except make the patient vomit, which could actually be dangerous if they were unconscious or semi-conscious. So, to summarize, DWale was a mixture containing three genuinely powerful and dangerous drugs: opium, henbane, and hemlock, along with several relatively harmless substances, bile, lettuce, vinegar, and bryony, all mixed together and given to the patient in wine. The wine itself was important. Alcohol enhances the effects of sedatives. It also makes them easier to drink. The bitterness of bile, the pungent taste of vinegar, the astringency of the plant extracts, all would be partly masked by wine. And if you were about to undergo surgery, a large drink of wine, even without the added drugs, would at least take the edge off your terror. The recipe calls for 3 spoonfuls of each ingredient to be mixed, and then 3 spoonfuls of the final mixture to be added to a large vessel of wine, about half a gallon. The patient would drink until they fell asleep. How much they drank varied. Some would lose consciousness after a few swallows. Others might drink half the vessel before the effects kicked in. There was no standardization, no careful calibration. It was trial and error, conducted on the patient's own body. And this brings us to the central problem of DWale. Even when the recipe was followed exactly, even when the ingredients were fresh and properly prepared, the outcome was unpredictable. The alkaloid content of the plants varied. The patient's individual physiology varied. Their weight, their age, their health, their history with these substances, all of these factors influenced how they responded. Some patients drank DWale and simply became drowsy, not nearly unconscious enough for surgery. Others drank it and fell into a sleep so deep that they never woke up. Others woke up, but were never the same. Their memories scrambled, their personalities altered by damage to the brain. DWale was a gamble, a desperate solution to an impossible problem. And the people who administered it, the housewives and monks and healers, knew it was dangerous. But they used it anyway, because the alternative, fully conscious surgery, was unthinkable. So how exactly did DWale work? When it worked, what was happening in the body? To understand that, we need to move from the herbalist garden into the realm of modern pharmacology. We need to see what these medieval healers could not. The molecules, the receptors, the cascade of neurochemical events that turn a drink into unconsciousness. We need to understand the science behind the sleep. The science behind the sleep, how DWale worked. To understand how DWale functioned as an anesthetic, we must first understand what anesthesia actually is. Modern general anesthesia involves 3 main components: unconsciousness, amnesia, and analgesia, the elimination of pain. Ideally, a surgical anesthetic provides all 3. The patient is unconscious, feels no pain, and has no memory of the procedure afterward. This is what we achieve today with sophisticated drug combinations and careful monitoring. DWale, in theory, attempted all 3 of these goals using medieval ingredients. But the mechanisms were crude, the dosing was imprecise, and the risks were enormous. To see how it worked when it worked, and why it so often went tragically wrong, we need to look at the pharmacology of each active ingredient. Let's begin with opium, the analgesic component. Opium contains more than 20 different alkaloids, but the most important for pain relief is morphine, typically making up around 10 to 15% of opium's total weight. When morphine enters the bloodstream, either through the digestive system after being swallowed or more quickly through the lungs if inhaled, it crosses the blood-brain barrier and binds to opioid receptors in the brain and spinal cord. These opioid receptors are part of the body's natural pain regulation system. The brain produces its own opioid-like substances, called endorphins and enkephalins, which bind to these receptors and reduce pain perception. Morphine works by hijacking this system. It binds to the receptors much more strongly than the body's natural substances, triggering a powerful suppression of pain signals. But morphine does more than just block pain. It also activates the brain's reward centers, producing a feeling of euphoria and deep contentment. This is why opiates are addictive. They make you feel not just the absence of pain, but the presence of profound well-being. For a medieval patient facing the terror of surgery, this psychological effect would have been almost as important as the physical pain relief. However, morphine has a critical side effect: respiratory depression. The same opioid receptors that control pain also influence the brainstem regions that regulate breathing. When these receptors are overstimulated by morphine, the automatic drive to breathe is reduced. A person under the influence of high-dose opiates takes fewer breaths per minute, and each breath is shallower. In extreme cases, breathing stops altogether, leading to death from oxygen deprivation. The lethal dose of morphine varies widely. For someone who has never used opiates, as little as 200 milligrams might be fatal. For someone with a tolerance, they might survive doses several times higher. Medieval practitioners had no way to measure morphine content or to know the patient's individual tolerance. They simply used 3 spoonfuls of opium and hoped for the best. Now let us consider henbane and its primary active ingredient, scopolamine, also known as hyoscine. This alkaloid belongs to a class of drugs called anticholinergics. They work by blocking acetylcholine, a neurotransmitter that is critical for many functions. In the brain, acetylcholine is involved in memory, attention, and alertness. Blocking it causes drowsiness, confusion, and, importantly, amnesia. This amnesia effect is what made scopolamine so valuable in historical anesthesia. A patient under the influence of scopolamine might be partially conscious during surgery, might even respond to commands, but would have no memory of the event afterward. Their brain was simply not forming new long-term memories. The pain signals were still being processed, but the recording mechanism was switched off. Scopolamine also has a sedative effect independent of its anticholinergic properties. It depresses the central nervous system, reducing overall neural activity. In moderate doses, this causes sleepiness and a dreamlike state. In higher doses, it causes delirium, hallucinations, and profound disorientation. Many of the MAD patients emerging from DWale were probably suffering from scopolamine toxicity, their grip on reality shattered by excessive anticholinergic activity in the brain. But scopolamine, like morphine, depresses respiration. Not as strongly, but enough that in combination with morphine, the effect is synergistic. Each drug makes the other more dangerous. This synergy is both the strength and the weakness of DWale. The combination of drugs allowed lower doses of each individual component to achieve unconsciousness. But it also meant that the toxic effects compounded. Then there is hemlock and its alkaloid, coniine. Coniine is a different beast entirely. It does not work on the brain. It works on the peripheral nervous system, specifically at the neuromuscular junction where nerves connect to muscles. Coniine blocks the nicotinic acetylcholine receptors at this junction, preventing nerve signals from reaching the muscles. The result is paralysis. The muscles simply stop responding. It begins in the extremities and moves inward toward the core of the body. A person poisoned by coniine will feel their legs go numb and weak, then their arms, then their trunk. Eventually, the paralysis reaches the diaphragm and the intercostal muscles, the muscles responsible for breathing. At that point, death is inevitable unless artificial respiration is provided. But here is the horrifying part. Coniine does not affect consciousness. A person paralyzed by coniine remains fully aware. Their mind is clear. They simply cannot move, cannot speak, and eventually cannot breathe. This is how Socrates died, conscious and coherent, until asphyxiation took him. In the context of DWale, the paralytic effect of coniine might seem desirable. If a patient must be held still during surgery, paralysis helps. But there is a nightmarish possibility. A patient given too much hemlock, but not enough opium, and henbane might be paralyzed, but conscious. They would feel everything, unable to scream, unable to move, a prisoner in their own body while the surgeon cut into them. There is no way to know how often this happened, but the possibility is chilling. The interaction between these 3 drugs, morphine, scopolamine, and coniine, is complex. They do not simply add together. They multiply. The respiratory depression caused by morphine is made worse by scopolamine. The paralysis caused by coniine makes it harder to breathe, even if the drive to breathe is still present. And the amnesia caused by scopolamine means that even if the patient wakes up, they may have no memory of what went wrong. Modern pharmacologists have attempted to reverse-engineer DWale using the principles of pharmacokinetics, the study of how drugs move through the body. Researchers at the University of Toronto, in a study published in 2014, calculated the likely effective dose and toxic dose for a typical DWale recipe. They found that the therapeutic window, the range between a dose that works and a dose that kills, was razor thin. For a 70-kilogram adult, the amount of morphine in 3 spoonfuls of opium would be somewhere between 30 and 100 milligrams, depending on the opium's potency. The lethal dose of morphine for an opiate-naive person is around 200 milligrams, but significant respiratory depression begins at much lower doses. Add in the scopolamine from henbane, roughly 5 to 10 milligrams, which also depresses respiration, and you're already approaching dangerous territory. Then add the coniine from hemlock, perhaps 3 to 5 milligrams, and you are playing with fire. The researchers concluded that DWale, when properly prepared, could indeed induce unconsciousness suitable for surgery. But the margin for error was so small that death from overdose was a very real risk with every administration. And because the alkaloid content of medieval plants was so variable, even following the recipe exactly did not guarantee a safe dose. There is one more factor to consider: the role of alcohol. The patient was not drinking the drug mixture straight. It was added to wine, half a gallon of it. Alcohol itself is a central nervous system depressant. It enhances the effects of sedatives, particularly morphine and scopolamine. A person who drinks a large amount of wine and then takes opiates is at much greater risk of respiratory depression than someone who takes the same dose of opiates on an empty stomach. This enhancement effect was almost certainly not understood by medieval practitioners. They included wine because it made the bitter mixture palatable, because alcohol was a common medium for medicines, and because getting the patient drunk seemed like a reasonable preliminary to surgery. They did not know that the alcohol was making the drugs more potent, pushing the dose closer to the lethal threshold. But here is the interesting twist. The University of Toronto researchers also found that the combination of scopolamine and morphine might have had an unexpected benefit. Scopolamine causes a sense of dissociation, a feeling of being detached from one's own body and surroundings. This effect kicks in quickly, within 20 minutes of ingestion. Morphine, by contrast, takes longer to reach peak concentration in the brain, around 60 to 90 minutes after oral administration. What this means is that a patient given DWale would first feel the dissociative effects of scopolamine. The world would become strange and distant. Their sense of self would blur. This dissociation might reduce the subjective horror of the situation even before the full analgesic effects of morphine arrived. And, crucially, the dissociation might reduce the patient's likelihood of accidentally overdosing themselves. If the wine containing DWale was left within their reach, a modern addict might drink more and more chasing a high. But someone in a state of scopolamine-induced dissociation would be less likely to have the motivation or coordination to continue drinking. This is purely speculative, of course. We have no accounts from medieval patients describing what DWale felt like. But it is possible that the combination of drugs, for all its dangers, was more sophisticated than it first appears. It was not just a matter of throwing together 3 poisons and hoping for the best. There may have been an emergent property from the combination, a synergy that made the whole greater than the sum of its parts. But synergy cuts both ways. The drugs work together to induce unconsciousness, and they work together to stop breathing. This was the fundamental problem with DWale. It could work. There were surely cases where it was successful, where a patient drank the mixture, fell into a deep sleep, underwent surgery without pain, and woke up with no memory of the ordeal and no lasting damage. If there were not, the recipe would not have been copied and recopied for centuries. But there were also cases where it failed catastrophically, where the patient drank DWale and never woke up, where they woke up but were left with permanent neurological damage, their minds scrambled by prolonged lack of oxygen or by toxic levels of anticholinergics, where they woke up in the middle of the surgery, paralyzed by coniine but conscious, experiencing the full horror of the knife. The problem was that you never knew which outcome you would get. Every use of DWale was an experiment, and the results were written on the patient's body. To truly understand DWale, we must see it in context. We must see the world in which it was used. A world of brutal necessity, where surgery was not a routine procedure scheduled weeks in advance, but an emergency intervention, often on the battlefield or in the immediate aftermath of trauma. We must see the blood, the screams, the stinking wounds, the desperate attempts to save lives with tools that were barely adequate and knowledge that was incomplete. We must enter the medieval surgery itself. Medieval surgery, the brutal reality. The medieval surgery was not a sterile operating theater. It was a room in a house, or a corner of a monastery infirmary, or a tent on a battlefield. It smelled of blood and sweat and unwashed bodies, and, if you were lucky, the sharp tang of vinegar used as a cleaning agent. The instruments were not sterilized. Sterilization was not a concept. They were cleaned, certainly scraped and washed after each use, but bacteria were not understood. Infection was not yet germ theory. It was miasma, bad air, or an imbalance of humors, or simply bad luck. The tools themselves were simple but effective. Knives of various sizes, some straight, some curved. Saws with coarse teeth for cutting through bone. Forceps and hooks for grasping tissue. Cauterizing irons that could be heated in a fire and used to burn wounds closed, sealing blood vessels. Needles and thread for stitching, though the concept of internal sutures, of sewing together layers of tissue, was not well developed. Mostly, wounds were cleaned, packed with lint or cloth soaked in honey or wine, and then bandaged. The body had to do the rest. Let us walk through a typical medieval surgical procedure, step by step, to understand what DWale was meant to spare the patient from experiencing. A soldier has been wounded in battle. An arrow has penetrated his thigh, driven deep by the force of a longbow. The arrow was removed in the field, but it was not a clean removal. The barbed head tore tissue as it came out, and fragments may remain. Now, 3 days later, the wound is hot, swollen, and beginning to smell. Red streaks are visible on the skin, running up toward the groin. This is blood poisoning, what we now know as septicemia. Without intervention, the man will be dead within a week. He is brought to a barber surgeon, the most skilled available. The surgeon examines the wound and makes his determination. The leg must come off. The infection is too far advanced. There is no antibiotic to stop it. The only way to save the man's life is to remove the infected limb before the poison spreads to the rest of the body. The patient knows what this means. He has seen amputations before. Everyone has. It is a common enough procedure in a time of constant warfare. He is terrified, but he consents. He wants to live. In an ideal situation, with an enlightened practitioner willing to use DWale, this is where the sleeping drink would be administered. The patient would drink the wine mixture, slowly at first, wary of the bitter taste despite the alcohol. He would be encouraged to drink more, and then, if the gods were kind, he would become drowsy. His eyes would flutter. He would lie down on the table, and consciousness would slip away. The surgeon would wait, watching for the signs. Slow, deep breathing, no response when his name was called, complete limpness when his arm was lifted and dropped. Only then would the surgery begin. But in reality, this scenario was rare. Most surgeons did not use DWale or any sleeping medicine. They relied instead on speed, restraint, and the grim hope that the patient's body could withstand the shock. So let us see what happened more typically without anesthesia. The patient is positioned on a sturdy table. His uninjured leg is strapped down. His arms are held by 2 strong assistants. Another assistant positions himself across the patient's chest, ready to press down if he tries to rise. The surgeon ties a tourniquet around the thigh. Above the infected area, a rope twisted tight with a stick to cut off blood flow. This is critical. Without it, the patient will bleed to death before the procedure is finished. The surgeon takes his knife. There is no warming up, no gradual process. He simply begins. He cuts in a circle around the thigh, slicing through skin and muscle in one continuous motion. The cut is deep, down to the bone. The patient screams. His body convulses. The assistants hold him down, straining against his strength. It is astonishing how strong a man can be when driven by pain. The surgeon works quickly. He peels back the skin and muscle, exposing the white gleam of the femur. Then he takes the saw. This is the part that takes the longest, and that produces the most terrible sound. The rasp of metal against bone, a grinding, scraping noise that seems to penetrate not just the ears but the teeth, the skull. The patient is no longer screaming in distinct cries. His voice is broken into a continuous, animal howl. The surgeon saws through the bone. It takes perhaps 90 seconds. Finally, the limb comes free. It is set aside, discarded. Now the surgeon must work quickly to stop the bleeding. Arteries are spurting blood despite the tourniquet. He takes a cauterizing iron, heated until it glows red, and presses it against the exposed blood vessels. There is a hiss, the smell of burning flesh. The patient, if he has not yet fainted from shock, does so now. The stump is wrapped in bandages soaked in wine and honey, or simply in clean cloth, if those are not available. The tourniquet is loosened slightly, then removed entirely if bleeding has stopped. The patient is carried away. He is still alive, barely. His face is gray. His breathing is shallow and rapid. He is in profound shock. Over the next few days, he will either recover or die. If the shock does not kill him that night, infection might. The wound, no matter how carefully cleaned, is now an open gateway for bacteria. If he develops fever, if the wound begins to smell, if red streaks appear again, there is nothing more to be done. The surgeon has cut as high as he dares. Another amputation higher up would almost certainly be fatal. Many patients did survive. Archaeological evidence from medieval cemeteries shows skeletons with healed amputation stumps. The bone has remodeled, the end smoothed over with new growth. These people lived for years, even decades, after their surgery. But they carried with them the memory of it. The nightmare of the knife, the saw, the iron. Many spoke of it in fragmentary, haunted ways, unable to fully describe the experience because there are no words adequate to that kind of pain. This is what DWale promised to prevent. And this is why, despite its dangers, people were willing to try it. Amputation was far from the only surgery performed in the medieval period. There was a wide range of procedures, from the relatively minor to the genuinely complex. Cataract couching, though we have mentioned it, deserves more detailed explanation. The patient would be seated, head held firmly by an assistant. The surgeon took a long, thin needle and inserted it through the white of the eye, just at the edge of the cornea. He then used the needle to push the clouded lens backward and downward, so that it fell to the bottom of the eye chamber, out of the line of sight. The patient, who had been seeing only blurry shadows due to the cataract, would suddenly be able to see clearly again, at least in the center of their vision. But the procedure was agonizing. The eye is one of the most sensitive parts of the body. Pushing a needle into it, while fully conscious, required not just courage but an almost superhuman ability to remain still. If the patient flinched at the wrong moment, the needle could puncture the lens, causing it to rupture and leak, or it could damage the retina at the back of the eye, resulting in permanent blindness. Many patients had to be physically restrained, head locked in place, while the surgeon worked. Bladder stone removal lithotomy has already been described, but it is worth emphasizing just how invasive this procedure was. The surgeon was cutting into one of the most infection-prone areas of the body, the perineum and urogenital tract. Post-operative infection was almost guaranteed. Patients developed abscesses, fistulas, sepsis. Even those who survived often had permanent damage, unable to urinate normally, suffering from incontinence or chronic pain. And yet men chose lithotomy over the alternative. The pain of a bladder stone, a hard calcified mass scraping against the delicate lining of the bladder with every movement, with every attempt to urinate, was described by those who experienced it as worse than anything else they had ever known. Childbirth, sword wounds, broken bones, nothing compared to the grinding, unrelenting agony of a stone. So they went under the knife, knowing the odds, because at least it offered the possibility of relief. Then there was trepanning. The drilling of holes into the skull had been practiced since Neolithic times. Skulls from prehistoric sites show evidence of trepanning, and many show signs of healing, meaning the patient survived the procedure. By the medieval period, trepanning was done for several reasons. The most medically sound was for depressed skull fractures. A blow to the head with a mace or hammer could drive a piece of skull inward, pressing on the brain. This caused symptoms ranging from severe headaches to seizures to loss of consciousness. The solution was to drill around the depressed fragment and remove it, relieving the pressure. But trepanning was also done for less rational reasons. Epilepsy, migraines, mental illness, even simple behavioral problems were sometimes attributed to demons or evil spirits trapped in the head. The hole was meant to let them out. We can look back on this and call it superstition, and certainly it was based on incorrect theory. But the procedure itself was technically sound, and in some cases, it may have inadvertently helped. A person suffering from chronic headaches due to increased intracranial pressure from a tumor or an accumulation of fluid would genuinely feel relief after a hole was drilled, allowing the pressure to equalize. The patient, however, experienced the full horror of having their skull pierced. The scalp was cut and peeled back, exposing the bone. The surgeon used a trephine, a circular drill with a handle, and applied steady downward pressure, rotating it back and forth. The grinding sensation, transmitted directly through bone to the brain, was indescribable. And then, the moment when the drill broke through. The patient could feel it, a sudden give, and then the surgeon was probing the opening, ensuring all the bone fragments were removed, while the brain pulsed visibly beneath, soft and vulnerable. Many survived trepanning, but many also developed infections of the brain tissue, meningitis, which was universally fatal in the pre-antibiotic era. There are also routine surgeries. Tooth extractions, as we have discussed, removal of cysts and tumors, lumps growing on the skin or just beneath it, lancing abscesses, cutting open boils to drain the pus, setting broken bones, which involved forceful manipulation, pulling and pushing until the bones slipped back into alignment. All of these were done without anything more than perhaps a cup of wine for courage. And there was battlefield medicine, its own special category of horror. Surgeons attached to armies dealt with arrow wounds, sword cuts, crush injuries from maces, puncture wounds from spears. Arrows were particularly challenging. If an arrow penetrated deeply and the head was barbed, simply pulling it out could tear blood vessels and cause fatal bleeding. The surgeon had to assess whether to push the arrow all the way through, out the other side, if it had not penetrated too far, or whether to make an incision and carefully cut around the arrowhead to remove it. One of the most famous surgical case studies from the medieval period involves Prince Henry, who later became King Henry V of England. In 1403, at the Battle of Shrewsbury, the 16-year-old prince was struck in the face by an arrow. The arrow entered below his left eye and embedded about 6 inches into his skull. The shaft broke off, leaving the arrowhead deep inside. The prince survived the battle and was taken back to a field hospital. The royal surgeon, John Bradmore, faced an extraordinary challenge. The wound was deep, in a highly sensitive area, and infection was already setting in. Bradmore designed a special tool, a kind of elongated screw extractor. He gradually widened the wound channel using probes of increasing diameter, each one infused with rose honey, an antimicrobial agent. After 20 days of careful, painful work, he finally extracted the arrowhead and saved the prince's life. Prince Henry survived, with a prominent scar, and went on to become one of England's most famous warrior kings. But the procedure took 3 weeks of daily interventions. Every day, Bradmore worked on the wound, with Prince Henry fully conscious. It is hard to imagine the pain, but it was that or death, and so the prince endured. This was the world of medieval surgery, a world where pain was the baseline expectation, where patients were held down, screaming, while surgeons worked as fast as they could, where survival was never guaranteed, and those who did survive often wished they had not, haunted by the memory of what they had endured. It was into this world that DWale arrived. A promise, a hope, a drink that could take away the pain, or at least the memory of it. And despite its dangers, despite the risk of death, people used it. Because anything was better than the knife. But who were these people? Who were the ones administering DWale? And more importantly, why did the surgeons themselves, the men who wielded the knives and saw the suffering firsthand, refuse to use it? To answer that, we must understand the strange and fractured world of medieval medicine. We must meet the practitioners. The practitioners, barber surgeons and physicians. Medieval medicine was not a unified profession. It was a hierarchy, sharply divided by class, education, and training. At the top were the university-educated physicians, literate men who had studied the classical texts of Galen, Hippocrates, and the Arabic masters. They wore long robes, spoke Latin, and concerned themselves with diagnosis and theory. They rarely performed surgery. That was beneath them. Below the physicians were the barber surgeons, craftsmen who learned their trade through apprenticeship. They were the ones who actually cut into flesh, who set bones, who extracted teeth. They were not educated in the formal sense. Most could not read Latin, but they had practical knowledge, learned through experience, passed down from master to apprentice over generations. And then, outside this official hierarchy, were the informal healers, wise women, monks, and ordinary housewives who kept remedy books and tended to the sick in their communities. These are the people most likely to actually use DWale. Let us begin with the surgeons, the ones who should logically have been the primary users of DWale, but who, paradoxically, were its loudest critics. Medieval surgeons were acutely aware of the problem of pain. They worked with it every day. They saw the suffering they caused, and many wrote about the difficulty of it. The great French surgeon Henri de Mondeville, writing in the early 14th century, observed that pain could kill as surely as a blade. He advocated for compassionate treatment of patients, for speaking to them gently, for minimizing their suffering where possible. And yet, surgeons repeatedly warned against the use of sleeping medicines. In every surgical text that mentions them, the tone is one of caution or outright prohibition. Why? The answer lies in control and predictability. Surgery in the medieval period was a delicate balance. The surgeon needed to work quickly, but he also needed to monitor the patient's condition constantly. A conscious patient, for all their screaming and thrashing, provided immediate feedback. If they suddenly went quiet, went limp, their color changed, the surgeon knew something was wrong. Perhaps a major blood vessel had been cut. Perhaps the patient was going into shock. The surgeon could adjust, could work faster, could call for assistance to apply pressure. But an unconscious patient provided no such feedback. A patient under the influence of DWale might appear peaceful, might seem to be tolerating the surgery well, and then simply stop breathing. By the time the surgeon noticed, it might be too late, and there was no way to reverse it. There was no naloxone, no modern antidote to opioid overdose. There is only vinegar and salt on the temples, a desperate hope to shock the patient back to consciousness. Worse, the effects of DWale were unpredictable. Some patients, given what appeared to be an adequate dose, would wake up halfway through the surgery. Suddenly, in the middle of cutting, the surgeon would find himself with a thrashing, screaming patient who had no idea where they were or what was happening. This was dangerous for everyone. The patient could injure themselves further. The surgeon could make a fatal slip with a knife. And then there was the legal question. If a patient died during surgery, the surgeon could be blamed. If they had used a controversial sleeping medicine, they were even more vulnerable to accusation. It was safer, legally and practically, to simply not use anesthetics at all. Work fast, rely on restraints, and let the patient scream. At least then, everyone understood what was happening. But there is another factor, darker and more cynical. Pain served a purpose in the surgeon's practice. A patient who knew what awaited them was careful about seeking surgery. They did not come for trivial complaints. They waited until their condition was truly desperate. This was, in a sense, a form of self-selection. Only those who genuinely needed surgery would submit to it. If surgery could be made painless, the calculation changed. Patients might seek operations for conditions that did not warrant the risk. The surgeon might be pressed to perform procedures that were not necessary, increasing the overall number of complications and deaths. Pain, paradoxically, protected patients by making them cautious. Whether medieval surgeons thought in these explicit terms is unclear, but their written warnings against sleeping medicines consistently emphasize that surgery should be avoided whenever possible, that it should be a last resort, and that patients needed to understand the gravity of the decision. Pain was part of that understanding. So if surgeons did not use DWale, who did? The answer appears to be housewives. This sounds strange to modern ears. We imagine anesthesia being administered by trained medical professionals in controlled environments. But in the medieval period, most medical care happened at home, and the primary caregivers were women. The evidence for this comes from where DWale recipes are found. They are not in surgical texts, the formal manuscripts written by and for educated surgeons. They are in domestic remedy books, small notebooks kept by literate women that contain a mixture of medical recipes, cooking instructions, household tips, and prayers. These books were intensely practical, designed for daily use. A typical domestic remedy book might contain a recipe for treating a burn, followed by instructions for making bread, followed by a prayer for childbirth, followed by a recipe for DWale. To the woman keeping this book, DWale was not a theoretical medical curiosity. It was a tool she might actually need to use if her husband or son or brother came home from war with a wound that required surgery. Medieval women were expected to be skilled in herbal medicine. They kept gardens of medicinal plants. They knew how to prepare poultices, tinctures, salves. They were the ones who sat up all night with sick children, who tended to the injured, who laid out the dead. When a barber surgeon was called to the house to perform an operation, it was often the lady of the house, or her housekeeper if she was wealthy, who prepared the patient, who gathered the necessary supplies, and who provided aftercare. And if DWale was to be used, it would be the housewife who prepared it. She would follow the recipe in her notebook, mixing the ingredients carefully, adding them to wine, and then giving the drink to the patient with the hope that it would spare him the worst of the pain. This was an enormous responsibility and an enormous risk. If the patient died, she could be blamed. If he was permanently damaged by the drug, she would carry that guilt. But if he survived, if the surgery was successful and he woke up with no memory of the ordeal, she had given him an extraordinary gift. She had done what even the educated surgeons could not. She had conquered pain. There is a poignant illustration from a 15th century manuscript that shows this scene. A medieval woman, dressed in the long gown and wimple of a respectable housewife, stands in her home. She is consulting a book, open to a page covered in dense handwriting. On the table before her are various bottles and vessels, ingredients for a remedy she is preparing. The caption identifies her as preparing medicine for the sick. She is the archetypal medieval housewife healer, the person most likely to have actually used DWale. Then there were the monks. Monasteries throughout Europe maintained infirmaries for their own sick and injured brothers, and many also provided care for travelers and the poor. Monastic medicine was sophisticated, informed by the translated texts from the Islamic world and by centuries of accumulated experience. Monks kept their own remedy books, though theirs were more likely to be in Latin. DWale recipes appear in some of these texts as well. The monastery at Monte Cassino, where some of the earliest European soporific recipes originated, almost certainly used them in practice. Monks, bound by vows of charity and service, would have been willing to take risks to relieve suffering. If a recipe existed that might help, they would try it, even knowing the dangers. But monks were also bound by obedience. If their abbot or the monastery's physician forbade the use of sleeping medicines, they would not use them. This created variation. Some monasteries embraced DWale. Others rejected it. There was no central authority dictating practice. And then there were the informal healers, the wise women and cunning men who operated entirely outside the official medical system. These were people with a reputation for healing, who might have some reading ability or might rely entirely on oral tradition. They were consulted for problems that the barber surgeon could not help with or would not touch: fertility issues, curses, love potions, and chronic illnesses. Some of these healers almost certainly knew about DWale, but whether they used it, and how often, is impossible to say. Their practices were not recorded. They did not write texts or keep detailed notes. What we know of them comes from court records, when they were accused of witchcraft or malpractice, and from the occasional dismissive mention in learned texts. One thing is clear: DWale was not confined to any single group. It crossed boundaries of class and education. It was known to the wealthy woman in her manor house, consulting her imported remedy book. It was known to the monk in his monastery infirmary, copying recipes from ancient manuscripts. And it was known, at least by reputation, to the ordinary villager who might turn to the local wise woman in desperation. What united all these practitioners was a willingness to gamble. To offer DWale was to accept the possibility of a bad outcome. It was to take responsibility for a life, knowing that you might end it. And bad outcomes were not rare. They were common enough that the dangers of DWale were well known. Every manuscript that records the recipe also includes warnings. This was not a remedy to be used lightly. So what happened when DWale went wrong? What did the sleep of the anesthetic turn into the sleep of death? And what were the consequences for those who survived but were changed by the drug? To understand that, we must look at the dark side of DWale. The failures, the tragedies, the reason why, for all its promise, it was a solution that many feared more than the pain itself. The dangers, when the sleep became eternal. The medieval manuscripts are rarely explicit about failures. Medical texts of the period tend to describe successes, or at least theoretical procedures, while glossing over disasters. But between the lines, in the warnings that accompany DWale recipes, in the literary references, in the few documented cases that survive, we can piece together what went wrong. The most common failure was simple. The patient never woke up. They drank the DWale, fell into what appeared to be a peaceful sleep, and then, sometime during or shortly after the surgery, their breathing slowed, became irregular, and stopped. Death by respiratory depression is quiet. There is no dramatic moment, no sudden crisis. The person simply stops breathing, and if no one notices quickly enough, the brain is deprived of oxygen for too long, and death is inevitable. For the person administering DWale, this must have been a nightmare. You give someone a drink meant to help them, meant to spare them pain, and instead you watch them die. And there is nothing you can do. You dab their temples with vinegar and salt, try to rouse them. You call their name. You shake them. Nothing. They are gone. The manuscripts acknowledge this possibility obliquely. One recipe, recorded in a 15th century English manuscript now held at the British Library, ends with a chilling note. They are perilous to drink, for peradventure they will grieve him ever after. Grieve him ever after is a euphemism. It means they might cause permanent harm or death. Another manuscript, from a different collection, is more direct. After listing the ingredients for DWale, it adds, "But this drink is dangerous, for it may slay a man. Use it not, but if need be great, for many have died of it." The problem was dosing. Every individual ingredient in DWale had a variable alkaloid content, depending on where and when it was harvested, how it was prepared, and how it was stored. Opium could be strong or weak. Henbane from one plant might be twice as potent as henbane from the plant next to it. Hemlock's toxicity varied with the season. And then there was the patient's individual physiology. A large, healthy man might tolerate a dose that would kill a smaller, weaker person. An older patient, whose liver and kidneys were less efficient at metabolizing drugs, might be poisoned by a dose that a younger person would handle easily. A patient who was already ill, whose body was fighting infection, might be pushed over the edge by the additional stress of the drugs. Medieval practitioners had no way to account for these variables. They followed the recipe, 3 spoonfuls of each, and hoped. Sometimes it worked. Sometimes it did not. But death was not the only bad outcome. There were fates arguably worse. Some patients woke up from DWale but were never the same. Their memories were scrambled. They could not remember their own names, their families, basic facts about their lives. This was particularly common with excessive henbane or mandrake, both of which contain anticholinergic alkaloids that interfere with memory formation. Acetylcholine is critical for consolidating short-term memories into long-term storage. Block it too aggressively, and the brain simply cannot record new experiences. A person might wake up able to function, able to walk and talk, but with no memory of the past day, week, or even month. And in some cases, the damage was permanent. The pathways for memory formation were disrupted, and they never fully recovered. Imagine waking up from surgery and realizing that you no longer remember your children's names, or that you can remember things from your youth, but nothing recent. Your wife stands beside your bed, and you do not know who she is. This happened. Families dealt with relatives who had lost their wits after receiving sleeping medicine. Other patients developed lasting neurological problems. Tremors, difficulty walking, slurred speech. These were likely the result of prolonged oxygen deprivation during the period of respiratory depression. The brain had survived, but neurons in certain regions had died from lack of oxygen. The damage was subtle but permanent. And then there were the patients who woke up insane. Anticholinergic toxicity, particularly from high doses of henbane or mandrake, can induce a state of delirium that lasts for days or weeks. The patient is agitated, confused, seeing things that are not there. They might become violent, lashing out at caregivers. They might strip off their clothes and wander away. They might speak in gibberish or not speak at all, staring at nothing. In the medieval period, this delirium was sometimes interpreted as demonic possession. The patient had gone under the knife, drunk the sleeping medicine, and come back wrong. Something evil had entered them. Exorcisms were performed. Prayers were said. Sometimes the patient recovered as the drugs slowly left their system. Sometimes they did not. There is a literary reference to this in the works of Geoffrey Chaucer, England's greatest medieval poet. In the Canterbury Tales, in the Reeve's Tale, Chaucer makes a passing reference to DWale. The context is sexual. Two young men have spent the night with a miller's wife and daughter, without the need for any sleeping potion, because the women were willing. Chaucer writes, "There was no more. They needed no DWale." This is a joke, but it tells us something important. By Chaucer's time, in the late 14th century, DWale was well enough known that it could be referenced in popular literature and the audience would understand. It was part of the cultural vocabulary. But the reference is also knowing, slightly dark. DWale is associated with unconsciousness, with loss of control, with a state in which things can be done to you without your knowledge. It is not purely medical. It has an edge of danger. In another medieval text, the 14th century allegorical poem Piers Plowman, DWale appears again, this time in a more explicitly negative context. The poem warns against the dangers of excessive sleep and sloth, using DWale as a metaphor for spiritual stupor. To be under the influence of DWale is to be cut off from God, to be in a state of sin. The poem's author, William Langland, was almost certainly aware of the medical use of DWale, but he transforms it into a symbol of moral danger. These literary references suggest that by the late medieval period, DWale had a reputation. It was powerful, it was dangerous, and it was associated with states of consciousness that were ambiguous, neither fully asleep nor fully awake, neither healing nor harming, but somewhere in between. Physicians of the time began to write more explicitly about the dangers. The Italian surgeon Theodoric of Servia, one of the most respected surgical writers of the 13th century, included a section in his work on anesthetics. He described the soporific sponge tradition and acknowledged that it could work. But he also warned that many patients have died from these medicines, and others have lost their minds. He went on to recommend that surgeons avoid them entirely and instead rely on speed and skill. Better to cause pain that the patient would remember and survive than to risk death or madness from a sleeping drug. This became the dominant position among educated surgeons. DWale and similar preparations were too dangerous to use. The risk outweighed the benefit. Pain was terrible, but death was worse. And yet, the recipes continued to circulate. They were copied into new manuscripts. They were passed down. Why? Because for some people, the risk was worth it. If you were the mother of a soldier who had come home with a shattered leg that needed to be amputated, and you knew that he might die from the shock of the pain, DWale offered a chance. A slim chance, but a chance nonetheless, that he might undergo the surgery in peace, without the trauma, without the screaming, without the horror that might break his mind even if his body survived. You would weigh the options. Pain and trauma, certain. Death from DWale, possible. And you might decide to take the gamble. The dosing problem was never solved in the medieval period. There was no way to standardize the preparation, no way to test the potency beforehand. Every use of DWale was a roll of the dice, with the patient's life as the wager. But what we can say, from the sheer number of manuscripts that record DWale recipes, is that it was used, not universally, not by the official medical establishment, but by individuals, in homes, in monasteries, in desperate situations where the alternative seemed even worse. It was used, and sometimes it worked, and sometimes it did not. And the memory of those failures, the patients who never woke, the ones who woke changed, must have haunted the people who administered it. They carried the weight of those deaths, those damaged minds, for the rest of their lives. But despite the dangers, despite the warnings, despite the fear, DWale persisted. For centuries, it remained part of the pharmacopoeia, an option, however risky, for those brave or desperate enough to try it. To truly understand DWale, we need to see it not just in theory, but in practice. We need to look at the historical record, at the manuscripts themselves, at the archaeological evidence, and at the few documented cases where we can see DWale being used, or at least referenced, in real situations. We need to meet the people who used it. DWale in practice, case studies and historical accounts. The frustrating thing about studying DWale is how little direct evidence we have of its actual use. Medieval medical practice was not documented in the way modern medicine is. There are no patient charts, no anesthesia logs, no records of doses administered and outcomes achieved. What we have are the recipes themselves, scattered across dozens of manuscripts, and a handful of literary and legal references that hint at real-world use. But from these fragments, we can piece together a picture. Let us start with the manuscripts. To date, researchers have identified over 50 different English manuscripts containing DWale recipes, spanning from the 12th century through the 15th. These manuscripts are geographically distributed across England, from the north to the south, from wealthy estates to modest households. This wide distribution suggests that knowledge of DWale was not confined to a single region or social class. One of the earliest known DWale recipes appears in a manuscript from the late 12th century, now held at the British Library, catalogued as Royal MS 12B12. The manuscript is a miscellany, a collection of various texts on medicine, natural philosophy, and household management. The DWale recipe appears on a page sandwiched between a treatment for eye infections and a charm to protect against lightning strikes. This eclectic mix is typical of medieval domestic remedy books, where the practical, the medical, and the spiritual existed side by side. The recipe itself is brief. For to make a man sleep while men carve him, take hemlock, opium, and the seeds of henbane. Mix with wine. Give him to drink. He shall sleep soundly. What strikes us immediately is how short this recipe is. It does not include the elaborate list of ingredients found in later versions. No bile, no lettuce, no bryony. Just the 3 active drugs, hemlock, opium, and henbane. This is either a simplified version or perhaps an earlier, purer form of the recipe before the additional ingredients were added. The manuscript also lacks any warnings about danger. It presents the recipe matter-of-factly, as if it were no more risky than a poultice for a headache. This suggests that at the time this manuscript was written, the full dangers of DWale might not have been widely recognized, or that the scribe who copied it considered the risk acceptable. By the 14th and 15th centuries, the recipes become more elaborate and the warnings more prominent. A manuscript from 1440, Cambridge University Library MSDD.6.29, contains one of the most detailed DWale recipes. It lists the now familiar 3 spoonfuls formula and includes a lengthy description of preparation. The opium must be good and fresh. The henbane seeds must be ground fine. The wine must be strong red wine, not thin or weak. This attention to detail suggests that practitioners were aware that the quality of ingredients mattered. They were trying, within the limits of their knowledge, to control variables and improve outcomes. The same manuscript includes a warning. This drink is perilous. Use it only when the man is in great danger of death from the knife, and let him drink only until he falls to sleep. Give him not too much, for he may never wake. This is crucial. The recipe acknowledges that DWale is dangerous, that it should be a last resort, and that dosing is critical. The instruction to stop giving the drink once the patient is asleep suggests an awareness that more is not better, that there is a point beyond which the patient is at risk. But how do you judge when someone is asleep enough? A patient might close their eyes, appear to sleep, but still rouse if cut. Or they might be so deeply unconscious that they are in danger. Medieval practitioners relied on observation. Slow, regular breathing, limpness, lack of response to being spoken to or touched. It was imperfect, but it was all they had. Some manuscripts include instructions for waking the patient if they appear too deeply asleep. If he sleeps too hard, dab his face with cold water and vinegar. Pinch his nose. Call his name loudly. If he does not wake, pray for him. That final instruction, pray for him, is telling. If the patient was too far gone, if the DWale had taken them beyond the point of recovery, there was nothing more to be done. The matter was in God's hands. The recipes also reveal regional variations. Manuscripts from the north of England are more likely to include bryony, a plant common in English hedgerows. Manuscripts from areas closer to monasteries with connections to Mediterranean trade are more likely to mention the option of using true mandrake if it can be obtained. One fascinating variation comes from a 15th century manuscript associated with the household of a wealthy merchant family in York. This version of DWale includes an additional ingredient, the juice of poppy flowers. Not the seed pod latex that produces opium, but the flowers themselves. Modern analysis shows that poppy flowers contain small amounts of alkaloids, enough to have a mild sedative effect, though nowhere near as potent as opium proper. The inclusion suggests that whoever wrote this recipe was experimenting, trying to find the right combination to maximize effectiveness while minimizing danger. But manuscripts are not the only evidence. There are literary references that give us glimpses of DWale in cultural context. We have mentioned Chaucer's reference in the Reeve's Tale, a knowing joke that his audience would have understood. But Chaucer's Canterbury Tales also includes another, more sinister, reference to sleeping potions in the Pardoner's Tale. 3 men plot to kill each other over gold. One of them goes to an apothecary and asks for poison to kill rats, but it is strongly implied that he intends to use it on his companions. The apothecary gives him a thing that in this world no creature that ate or drank of this mixture, but at once he should forsake this life. Yeah, he should die unless while thou wouldst walk a mile. This poison is so strong and violent. The poison is not explicitly named, but the context, an apothecary selling a substance that induces death-like sleep, suggests something in the family of DWale ingredients. The story does not end well. All 3 men die, poisoned by their own greed. It is a moral tale, but it also reflects the reality that these substances existed, that they were available, and that they were known to be deadly in the wrong hands. In the legal records, we occasionally find cases involving sleeping medicines. In 1302, a case was brought before the King's Court in London involving a woman named Alice, who was accused of killing her husband with a sleeping draught. The records are fragmentary, but they indicate that Alice had given her husband a drink to make him sleep through a sickness, and he had never woken. Whether this was DWale specifically or another sedative preparation is unclear, but the case shows that the use of such medicines was sometimes a matter for legal scrutiny. Another legal case, from 1387, involves a monk at a monastery in Northumbria who was accused by a fellow monk of using evil medicines to harm him. The accusing monk claimed he had been given a drink that caused him to lose his wits and see demons. Again, the specific substance is not named, but the description, loss of sanity, hallucinations, fits the profile of anticholinergic poisoning from excessive henbane or mandrake. The case was eventually dismissed, but it illustrates that sleeping medicines had a reputation, and that their misuse could lead to serious accusations. Beyond England, there is evidence from other parts of Europe. The Italian physician and surgeon DWale, writing in the 14th century, mentioned soporific sponges and potions in his influential work Chirurgia Magna. He describes their use, but cautions against relying on them. He notes that some surgeons in Italy use these preparations, but he personally prefers to work quickly rather than risk the patient's life with uncertain anesthetics. The famous Swiss physician Paracelsus, writing in the early 16th century, describes a preparation he calls sweet vitriol, which is ether, and praises its ability to quiet all suffering and relieve all pain. But he also mentions older herbal preparations, including those containing opium and henbane, and he criticizes them as too dangerous. Paracelsus is often seen as a transitional figure, moving from medieval herbal medicine toward modern chemistry, and his writings reflect a growing skepticism about complex herbal mixtures like DWale. From the archaeological record, we have indirect evidence. Excavations of medieval hospital and monastery sites have uncovered seed remains and plant residues. Henbane seeds have been found at several monastic sites, including the infirmary complex at the Abbey of St. Mary in York. Opium residues, identifiable by their chemical signature, have been detected in ceramic vessels from the 14th and 15th centuries, though we cannot know what they were used for. More telling is the skeletal evidence. Archaeologists have examined bones from medieval cemeteries, looking for signs of surgical intervention. Some skeletons show healed amputation stumps with evidence of careful surgical technique. Others show catastrophic injuries that were clearly not survivable. But there is a small subset that is interesting: individuals with surgical evidence, amputations or trepanning, who died shortly after the procedure and whose skeletal chemistry shows elevated levels of alkaloids consistent with opium or other plant-based drugs. This is not definitive proof of DWale use, as these substances could have been administered after surgery as pain relief. But it raises the possibility that some medieval surgeries were indeed conducted under the influence of anesthetics, and that some patients died either from the surgery itself, from infection, or from the anesthetic. One particularly intriguing case comes from the excavation of a mass grave in France, dating to the early 15th century, associated with a battlefield from the 100 Years' War. Among the remains were several individuals with evidence of amputations that appeared to have been performed shortly before death. Chemical analysis of one individual's bones showed traces consistent with opium and henbane exposure. The interpretation is tentative, but it suggests that military surgeons on campaign might have used DWale or similar preparations to perform emergency amputations on wounded soldiers. Whether these men died from their wounds, from infection, or from the anesthetic, we cannot know. But the presence of the alkaloids indicates they were given some form of medicinal preparation involving these plants. All of this evidence, fragmentary and scattered as it is, points to the same conclusion. DWale was not just a theoretical recipe preserved in manuscripts. It was actually used. Not frequently, perhaps not successfully most of the time, but it was part of the medieval medical toolkit, at least in certain contexts. And for every documented case, there were likely dozens or hundreds that left no trace. A housewife administering DWale to her injured husband in a remote village, the outcome recorded nowhere except in family memory. A monk in an isolated monastery, trying a recipe from an old text to ease the suffering of a dying brother. These stories are lost to us, but they happened. DWale was real. It was used, and it mattered to the people who took that terrible gamble. But to fully appreciate DWale, we must look more closely at its ingredients, not just as a list of names, but as plants with their own histories, their own cultural meanings, their own dangers. Each ingredient in DWale has a story, and those stories intertwine with the larger history of medicine, magic, and the search for substances that can alter consciousness. Let's meet the plants themselves. The deadly ingredients. A deeper look. The plants that made up DWale were not obscure or rare. They grew in gardens, in fields, along roadsides and riverbanks throughout Europe. They were familiar to medieval people in a way that they are not to us. A farmer would recognize henbane by its smell, could point out hemlock by its distinctive spotted stem, knew to avoid the berries of deadly nightshade. These plants were part of the landscape, woven into the seasonal rhythms of planting and harvesting, of gathering medicinal herbs and avoiding poisons. But familiarity did not mean they were safe. Quite the opposite. These plants occupied a liminal space in medieval culture, valued for their medicinal properties but feared for their toxicity, associated with healing but also with witchcraft and the devil. They were powerful, and power always carries risk. Let us begin with mandrake. Though strictly speaking, mandrake was not in most English DWale recipes, having been replaced by bryony. But mandrake is the ingredient, the original soporific plant, and its story is too extraordinary to ignore. Mandrake, Mandragora officinarum, is a Mediterranean plant with a thick, fleshy root that can grow 2 feet long, and that branches in ways that sometimes resemble a human figure, complete with what might be legs, arms, even a head. This anthropomorphic quality made mandrake one of the most legendary plants in history. The ancient Greeks believed mandrake had magical properties. Dioscorides, the first-century physician whose work, De Materia Medica, was the foundation of herbal medicine for 1,500 years, described mandrake in detail. He noted its power to bring sleep, to dull pain, and to cause vivid dreams. He recommended it for surgery, for insomnia, for melancholy. He also noted its toxicity and cautioned against excessive use. But mandrake's reputation went far beyond medicine. It became entangled with magic, fertility, and the supernatural. In the biblical book of Genesis, Rachel and Leah, wives of Jacob, compete over mandrake roots, which were believed to aid in conception. In medieval Europe, mandrake roots were said to scream when pulled from the ground, and the scream was fatal to anyone who heard it. The solution, according to legend, was to tie a dog to the plant and then lure the dog away with food. The dog, in pulling free, would uproot the mandrake. The dog might die from the scream, but the herbalist, safely distant with their ears covered, would survive. This elaborate ritual is depicted in countless medieval manuscripts, a testament to how seriously the danger was taken. Of course, mandrake does not actually scream, but the legend served a purpose. It made people cautious about gathering the plant, which was genuinely poisonous. The ritual ensured that only those who were serious, who understood the risks, would attempt to harvest it. Mandrake contains tropane alkaloids, particularly scopolamine and hyoscyamine. These are the same alkaloids found in henbane and deadly nightshade. They cause sedation, hallucinations, delirium, and in sufficient doses, death. For surgery, a carefully measured amount of mandrake could induce unconsciousness. Too much, and the patient would never wake. In England, true mandrake did not grow. It required the warmer, drier climate of southern Europe. English herbalists knew about it from translated texts and from imported roots, which were expensive and rare. So they substituted bryony, a native plant whose root was large and fleshy like mandrake's. But bryony, Bryonia dioica, lacks the tropane alkaloids. It was primarily a purgative, causing vomiting and diarrhea. Its inclusion in DWale was based on appearance and tradition, not on actual effectiveness. This substitution may have inadvertently made English DWale less dangerous than Mediterranean versions, since the most potent sedative ingredient was missing or reduced. Now let us turn to henbane, a plant that truly did grow in England, and that was central to many DWale recipes. Henbane, Hyacinthus niger, is a member of the nightshade family. It is a coarse, hairy plant with a distinctly unpleasant smell, often described as fetid or like rotting meat. Its flowers are pale yellow with purple veins, and the entire plant is covered in sticky hairs. It grows on waste ground, in abandoned fields, along roadsides. It is not a plant you cultivate in your garden. It simply appears, opportunistic and hardy. Henbane has been used as a medicine since ancient times. The Greeks and Romans knew its sedative properties, but it was also feared and associated with dark magic. In medieval Europe, henbane was one of the primary ingredients in witches' ointment, a preparation that witches were said to apply to their skin before flying to their sabbaths. Modern analysis of these ointments, based on recipes recorded during witch trials, shows they typically contain a mixture of henbane, deadly nightshade, and mandrake, combined with a fatty base like lard. When absorbed through the skin, the tropane alkaloids cause powerful hallucinations, sensations of flying or floating, loss of time, and profound disorientation. A person who applied such an ointment might genuinely believe they had flown through the air and attended a gathering of devils, when in reality, they had experienced a drug-induced hallucination while lying in their own home. But henbane was also legitimately medicinal. In small doses, it was used to treat toothaches, the seeds being heated over charcoal and the fumes inhaled. It was used as a sedative for anxiety and insomnia, and it was a key ingredient in surgical anesthetics. The challenge was dosing. The alkaloid content of henbane varies wildly. A plant growing in rich soil with plenty of water might have twice the scopolamine content of a plant growing in poor, dry conditions. A leaf picked in spring might be different from a leaf picked in fall, and the alkaloids are concentrated in the seeds more than in the leaves. There was no way for a medieval herbalist to test potency. They simply used 3 spoonfuls of henbane juice, or a handful of henbane seeds, and hoped they had judged correctly. The symptoms of henbane poisoning were well known. First came drowsiness and confusion, then hallucinations, often of a disturbing nature, visions of demons, animals, or distorted human figures. The pupils would dilate, making the eyes appear huge and black. The skin would become flushed and dry. The heart would race. In severe cases, the person would become violent, thrashing and screaming at things no one else could see. And then, if the dose was high enough, seizures, coma, and death. For a patient given DWale, the henbane would ideally induce a gentle drowsiness and amnesia, a forgetting of the surgery. But if too much was used, they might wake in a state of delirium, unable to distinguish reality from hallucination, terrified and inconsolable. This must have been horrifying for everyone involved. Next, hemlock, perhaps the most feared of all DWale's ingredients because of its association with death and execution. Hemlock, Conium maculatum, is a tall plant with hollow stems and delicate white flowers arranged in umbels. It is often confused with similar-looking edible plants like wild carrot or parsley, which has led to numerous accidental poisonings throughout history. The key identifier is the stem, which is mottled with purple blotches, like blood spots, and the smell, when crushed, is unpleasant, often compared to mouse urine. Every part of the plant is poisonous, but the seeds and roots are most toxic. The active compound is conium, an alkaloid that attacks the peripheral nervous system. It is a neurotoxin that blocks the transmission of signals from nerves to muscles, causing paralysis. The death of Socrates, as described by Plato, is the most famous hemlock poisoning in history. Socrates drank a cup of hemlock extract as his court-ordered execution. According to Plato, Socrates felt a cold numbness spreading from his feet upward, gradually paralyzing his legs, then his trunk, then his chest. He remained conscious and able to speak until the very end, discussing philosophy with his students. Finally, the numbness reached his heart and lungs, his breathing stopped, and he died. This is the horror of hemlock poisoning. You die conscious, feeling happen, unable to move or cry out as your body shuts down from the outside in. It is a death that respects the mind while destroying the body. In the context of DWale, hemlock's paralytic effect might seem useful. A paralyzed patient does not thrash or struggle during surgery. But the line between therapeutic paralysis and fatal paralysis is impossibly thin. And the idea that a patient might be paralyzed but conscious, feeling every cut of the knife but unable to scream, is a nightmare scenario. Why then was hemlock included in DWale? The most charitable interpretation is that medieval practitioners observed that hemlock caused numbness and paralysis, and reasoned that this would reduce pain sensation. They may have also hoped that in combination with opium and henbane, the doses of each could be kept low enough to avoid the worst effects of any single drug. It was a theory of synergy, and there was some logic to it, even if the execution was perilous. Finally, opium, the most reliable and effective of DWale's ingredients, but also the most addictive and the most likely to cause death by overdose. Opium, the dried latex of Papaver somniferum, has been used as a medicine for thousands of years. The Sumerians called the poppy the joy plant. The Egyptians included opium in their medical papyri. The Greeks and Romans used it extensively. By the medieval period, opium was well established as the most powerful pain reliever available. Opium works by binding to opioid receptors in the brain and spinal cord, blocking pain signals and inducing euphoria. It is extraordinarily effective. A person in severe pain, given opium, experiences relief that is immediate and profound. The pain does not disappear entirely, but it becomes distant, no longer overwhelming. And there is a warmth, a sense of well-being, a detachment from worry and fear. This is why opium has been used continuously for millennia. It works. And for someone facing the agony of medieval surgery, opium was a genuine mercy. But opium is also addictive. The body quickly builds tolerance, requiring higher and higher doses to achieve the same effect. And opium suppresses respiration. Too much, and breathing slows, becomes shallow, and stops. Death from opium overdose is peaceful. The person simply slips into unconsciousness and never wakes. But it is just as final as any other death. In the medieval period, the opium used in England was imported, often from the Eastern Mediterranean or from Islamic regions. It arrived as dried balls or cakes of hardened latex, dark brown or black. These would be dissolved in wine or water to create a liquid that could be measured and administered. But again, potency varied. Opium is graded by its morphine content, but medieval importers had no way to test this. A batch of opium from one region might be twice as strong as a batch from another. A practitioner following a DWale recipe that called for 3 spoonfuls of opium might be using a weak batch, in which case the patient would not achieve adequate sedation. Or they might be using a strong batch, in which case the patient would overdose. It was a lottery. Every time DWale was administered, the outcome was uncertain. Together, these 3 plants, opium, henbane, and hemlock, formed the active core of DWale. The other ingredients, bile, lettuce, bryony, vinegar, were either inert or had only minor effects. But these 3 were genuinely powerful, capable of inducing unconsciousness, amnesia, and analgesia. They were also genuinely dangerous, each one capable of killing in excessive doses, and their combination made the toxicity exponentially worse. Medieval practitioners who used DWale were working with forces they did not fully understand. They knew the plants worked. They knew they were dangerous, but they did not know about alkaloids, about neurotransmitters, about pharmacokinetics. They were feeling their way in the dark, guided by tradition and observation, taking enormous risks in the hope of relieving suffering. Sometimes they succeeded, sometimes they failed, and the failures, the deaths, the damaged minds must have weighed on them terribly. But for all its dangers, for all its failures, DWale represented something important. It represented an attempt to conquer pain, an attempt that predates modern medicine by centuries. And it is worth asking, why did DWale eventually disappear? What replaced it? And what did the medieval period teach us that still matters today? To answer that, we must look at the decline of DWale and the rise of newer, more reliable methods of pain management. The decline, why DWale disappeared. By the early 16th century, references to DWale begin to thin out. The manuscript tradition continues, but with less frequency. The recipes are still being copied, but often with additional warnings, with explicit statements that these preparations are old-fashioned, that they are dangerous, that they should not be used. What happened? The decline of DWale was not the result of a single event or discovery. It was a gradual process driven by multiple factors: changes in medical practice, the introduction of new substances, the growth of skepticism toward complex herbal mixtures, and the simple accumulation of bad outcomes that made people wary. Let us start with the cultural shift. The late medieval period, roughly the 15th century, saw the beginning of what would become the Renaissance. There was a renewed interest in classical texts, particularly Greek and Roman medical works, but also a growing emphasis on direct observation and experimentation rather than simply copying ancient authorities. Surgeons began to question the wisdom of using sleeping medicines. If the greatest physicians of antiquity, Galen and Hippocrates, had not emphasized anesthetics, if they had relied instead on speed and skill, perhaps that was the correct approach. Medieval physicians had enormous respect for classical authority. If the ancients had not used DWale, why should they? This is somewhat ironic, because the ancients had used soporific preparations. The soporific sponge tradition, after all, originated in the classical world and was developed further in the Islamic Golden Age. But by the late medieval period, the awareness of this tradition was fading in Western Europe, or at least being downplayed. At the same time, surgical technique was improving. Surgeons were becoming faster, more precise. The best could perform an amputation in under a minute, a lithotomy in 2. If speed could minimize pain, then the need for unreliable and dangerous anesthetics was reduced. There is also a legal and professional dimension. As surgery slowly gained respectability, as guilds and regulations were established to control who could practice, surgeons became more cautious about using controversial methods. Using DWale opened a surgeon to criticism and potential legal liability if the patient died. It was safer, professionally, to stick to conventional methods. But the most important factor in DWale's decline was the introduction of a new substance that offered pain relief without the same level of risk: laudanum. Laudanum was a preparation of opium dissolved in alcohol, essentially a tincture. It had existed in various forms for centuries, but it was popularized in the early 17th century by the Swiss physician Paracelsus. Paracelsus called his version laudanum, meaning worthy of praise, and promoted it as a cure-all. Unlike DWale, laudanum contained only one active ingredient: opium. This made it more predictable. The effects were consistent. You could titrate the dose, giving a little, observing the effects, and giving more if needed. There was still a risk of overdose, but it was easier to manage than with a complex mixture of multiple poisonous plants. Laudanum became widely used by the 17th century for pain relief, for sleep, and for a variety of ailments from diarrhea to coughs. It was not typically used as a surgical anesthetic in the modern sense, because the doses required to induce unconsciousness were dangerously high. But it was used for post-surgical pain management and for making patients drowsy and compliant before procedures. Laudanum was legal, socially acceptable, and widely available. It did not have the sinister reputation of DWale, with its associations of witchcraft and death. A physician could prescribe laudanum without fear of being accused of poisoning his patient. By the mid-17th century, DWale had largely disappeared from medical practice. The recipes were still preserved in old manuscripts, but they were no longer being actively used. When Thomas Bonham published a collection of surgical recipes in 1630, he included a version of DWale, but he presented it as a historical curiosity, something from an earlier age, not as a current practice. The final nail in the coffin for DWale was the rise of printed books. The printing press, invented in the mid-15th century, gradually transformed medical knowledge. Instead of manuscripts hand-copied by scribes, each one potentially containing errors or variations, there were now standardized printed texts that could be reproduced identically hundreds of times. Printed medical books tended to favor simpler recipes and more systematic approaches. The complex, multi-ingredient folk remedies of the manuscript tradition began to look old-fashioned, superstitious. Modern medicine, such as it was, favored single-ingredient drugs that could be standardized and whose effects were predictable. DWale, with its grab bag of ingredients, its variable potency, its terrifying risks, was a relic of an earlier age. It belonged to the world of wise women and domestic remedy books, not to the world of university-educated physicians and printed pharmacopoeias. But the disappearance of DWale did not mean the problem of surgical pain had been solved. Far from it. Surgery in the 17th and 18th centuries remained brutal and agonizing. Patients still underwent amputations while fully conscious. They still screamed. They still died of shock. What had happened was that the medical establishment had decided the risks of existing anesthetics were too great, and that it was better to endure pain than to risk death from poisoning. This was, in a sense, a rational decision, but it also meant abandoning the attempt to conquer surgical pain, at least for a time. There were some innovations. Surgeons experimented with various forms of distraction and psychological preparation. Some used music, having musicians play loudly to drown out screams. Others employed hypnosis, though this was not called hypnosis at the time. A skilled practitioner could sometimes talk a patient into a trance-like state of focused attention where they reported feeling less pain. And there were experiments with new substances. Paracelsus had mentioned ether, a volatile liquid that could induce sleepiness when its fumes were inhaled. But he had only tested it on chickens, and no one pursued the idea seriously for human use. In the late 18th century, nitrous oxide, laughing gas, was discovered by the British chemist Humphrey Davy. Davy noticed that inhaling the gas caused euphoria and seemed to reduce sensitivity to pain. He even suggested, in 1800, that it might be useful for surgery. But the medical establishment ignored him. Nitrous oxide became a party drug, used for recreational purposes at laughing gas parties, but not for medicine. It would not be until the 1840s that modern anesthesia was finally invented. Ether was used successfully for surgery in 1842 by Crawford Long in Georgia. Nitrous oxide and chloroform followed shortly after. Within a decade, general anesthesia had transformed surgery. Patients could now undergo operations while completely unconscious, feeling no pain, having no memory of the procedure. The age of anesthesia had arrived, and DWale, the medieval predecessor, was forgotten. But should it be forgotten? Or does DWale have something to teach us? Legacy and modern parallels. From a modern medical perspective, DWale looks like a disaster waiting to happen. A mixture of variable potency plant extracts, no standardization, no ability to monitor the patient, no antidotes if things went wrong. It was dangerous, it was unreliable, and it had a high rate of catastrophic complications. And yet the core idea was sound. DWale attempted to do something that we now do routinely: induce unconsciousness using a combination of drugs that work synergistically to provide analgesia, amnesia, and sedation. Modern anesthesia uses the same principle, though with synthetic drugs that are precisely calibrated and carefully monitored. Modern general anesthesia typically involves three classes of drugs. First, an induction agent to quickly render the patient unconscious, such as propofol. Second, an analgesic to block pain, often an opioid like fentanyl. Third, a neuromuscular blocker to induce paralysis, which makes surgery easier and prevents the patient from moving. This is strikingly similar to the three components of DWale: opium for analgesia, henbane for amnesia and unconsciousness, and hemlock for paralysis. Of course, modern drugs are incomparably safer. They have been tested in clinical trials. Their pharmacokinetics are well understood. Doses are measured precisely. Patients are monitored continuously with pulse oximeters, blood pressure cuffs, ECG machines. If something goes wrong, there are antidotes and interventions available. The anesthesiologist can adjust the drug levels in real time, keeping the patient in the optimal zone of unconsciousness without allowing them to slip into dangerous depths. But the basic strategy, using a combination of drugs to achieve multiple effects, is the same. DWale was crude, but it was on the right track. There's another parallel that is even more direct. In the late 19th and early 20th centuries, a technique called twilight sleep was used in obstetrics. This involved the combination of morphine and scopolamine, the very same alkaloids found in opium and henbane. Women in labor were given this mixture. They remained semi-conscious, moaning and moving, but not fully aware. Afterward, they had no memory of the birth. Twilight sleep was controversial. Critics pointed out that the women often thrashed and screamed despite appearing unconscious, suggesting they were experiencing pain but simply not remembering it. There were also cases of respiratory depression and other complications. By the mid-20th century, twilight sleep was largely abandoned in favor of epidurals and other methods that provided genuine pain relief without the amnesia. But for several decades, twilight sleep was popular, and it worked on the exact same pharmacological principles as DWale. It was, in a sense, DWale updated with purified alkaloids and better dosing. The problems were similar: difficult to control, risk of complications, and the disturbing question of whether amnesia alone, without true analgesia, was ethical. In the 21st century, there has been a renewed interest in historical pharmacology. Researchers are looking at ancient and medieval medical recipes not as quaint superstitions, but as potential sources of new medical knowledge. Plants that were used for centuries must have had some genuine effects. The reasoning goes, otherwise they would not have persisted in the medical tradition. The University of Toronto study we mentioned earlier, which analyzed the pharmacology of medieval DWale, is an example of this approach. By reverse engineering the recipe and calculating the likely drug concentrations, researchers were able to show that DWale, when properly prepared, could indeed induce surgical anesthesia. They also found that the combination of scopolamine and morphine might have had unexpected benefits, with the scopolamine reducing the likelihood of accidental overdose. This kind of research does not mean we should start using DWale again. Modern anesthetics are far safer and more effective. But it does suggest that medieval practitioners, working within their limited understanding, had stumbled onto something that actually worked. They deserve credit for that. There are also lessons about risk and benefit. Medieval people were willing to accept risks that we find unacceptable today. A 10% chance of death from anesthesia would be considered malpractice now, but in a world where untreated infections routinely killed, where life expectancy was 30 to 40 years, where death was a constant presence, the calculus was different. If DWale gave you a 90% chance of surviving surgery with less trauma, and the alternative was certain agony and a 50% chance of dying anyway, DWale was a reasonable gamble. This reminds us that medical ethics are not absolute. They are contextual. What is acceptable depends on what alternatives exist. Medieval practitioners were not foolish or cruel for using DWale. They were doing the best they could with what they had. There is also something to be said for the democratization of medical knowledge. DWale recipes appeared in domestic remedy books, accessible to literate housewives, not just to trained physicians. This meant that ordinary people, women in particular, had some agency in medical decision-making. They were not entirely dependent on professional practitioners who might not be available or affordable. The modern medical system is highly professionalized, which brings enormous benefits in terms of safety and efficacy, but it also creates barriers. Medical knowledge is inaccessible to lay people. We depend entirely on experts. The medieval tradition of domestic medicine, for all its flaws, empowered individuals to care for their families and communities. This is not to romanticize medieval medicine, which was often ineffective and sometimes harmful. But it is worth recognizing that the loss of accessible medical knowledge has costs as well as benefits. Finally, DWale reminds us of the central importance of pain management. For most of human history, pain was simply something to be endured. The idea that we could eliminate pain, that we could undergo major surgery without suffering, was almost unthinkable. Today, we take anesthesia for granted. We expect that if we need surgery, we will be unconscious, that we will not feel anything, that we will wake up with the procedure completed and only manageable postoperative pain. This is an incredible privilege. It is one of the greatest achievements of modern medicine. But pain management remains an ongoing challenge. The opioid epidemic has shown us that the same drugs that relieve pain can also destroy lives through addiction. Finding the balance, providing adequate pain relief without creating dependency, is one of the major challenges of contemporary medicine. In this context, the history of DWale is instructive. Opium was the most effective pain reliever in DWale, but also the most dangerous and addictive. Medieval practitioners understood this trade-off, even if they did not have our language of addiction neuroscience. They used opium because pain was worse than the risk. We face the same dilemma today, with more sophisticated tools, but the same fundamental tension between relief and risk. So DWale, though forgotten, though no longer used, still has something to teach us about the history of anesthesia, about the persistence of medical innovation even in difficult circumstances, about the willingness to take risks for the sake of reducing suffering, and about the long, difficult journey from the medieval surgery, with its screams and blood and desperate remedies, to the modern operating room, with its quiet machines and invisible gases and miracles that happen while we sleep. DWale was a step on that journey, a flawed step, a dangerous step, but a step nonetheless. And it deserves to be remembered, not as a curiosity or a cautionary tale, but as part of the larger human story of the struggle against pain. The long shadow, from DWale to modern anesthesia. The gap between the decline of DWale in the 16th century and the discovery of modern anesthesia in the 1840s was a dark time for surgical patients. For nearly 3 centuries, surgery was performed with no effective anesthesia beyond alcohol, and sometimes not even that. Surgeons became faster, more skilled, more precise. But patients still screamed. The breakthrough, when it finally came, was almost accidental. In 1842, an American physician named Crawford Long was working in rural Georgia. He had noticed, at social gatherings where people inhaled ether fumes for recreational purposes, that those who fell and injured themselves while intoxicated seemed to feel no pain. Long wondered if ether could be used medically. He tried on a patient who needed a neck tumor removed. He soaked a towel in ether and had the patient inhale the fumes. The patient fell asleep. Long removed the tumor. The patient woke up and reported feeling no pain during the procedure. Long's discovery was revolutionary, but he did not publish his results immediately. He was a modest man, unsure if his observation was significant. Meanwhile, other physicians and dentists were experimenting with similar substances. In 1844, a dentist named Horace Wells attended a demonstration of nitrous oxide, laughing gas. He saw a man under the influence of the gas injure himself without apparent pain. Wells immediately recognized the potential. The next day, he had a colleague extract one of his own teeth while he was under the influence of nitrous oxide. He felt nothing. Wells tried to demonstrate his discovery publicly, but the demonstration went poorly. The patient cried out during the procedure, and Wells was ridiculed. Discouraged, he abandoned his work on nitrous oxide. Then in 1846, a dentist named William Morton, who had learned about anesthesia from Wells, conducted a public demonstration at Massachusetts General Hospital in Boston. Using ether, he anesthetized a patient who then underwent surgery to remove a tumor from his neck. The patient remained unconscious throughout. The surgeon, John Collins Warren, turned to the audience after completing the operation and famously said, "Gentlemen, this is no humbug." News of successful ether anesthesia spread rapidly. Within months, surgeons across America and Europe were using it. The age of anesthesia had truly begun. Chloroform, discovered shortly after, became even more popular, especially after Queen Victoria used it during childbirth in 1853, giving it royal approval. These new anesthetics had enormous advantages over DWale. They were inhaled, which meant their effects were immediate and could be adjusted in real time by increasing or decreasing the concentration. They wore off quickly when administration stopped, so the patient would wake up naturally. And most importantly, they were pure substances. There was no variation in potency. Ether was ether. Chloroform was chloroform. Dosing was still an art, but it was far more predictable than mixing plant extracts. But these early anesthetics were not without risks. Ether was highly flammable. Chloroform could cause fatal cardiac arrhythmias. Many patients died during the early years of anesthesia from overdoses or unexpected complications. The learning curve was steep and paid for in lives. Over time, anesthesia became safer. Physicians developed better understanding of dosing. Specialized anesthesiologists emerged as a distinct profession. New drugs were synthesized. Monitoring equipment was invented. By the mid-20th century, general anesthesia was routine and relatively safe. Today, modern anesthesia is one of the miracles of medicine. A patient undergoing major surgery receives a carefully calibrated cocktail of drugs, an induction agent to quickly render them unconscious, an opioid analgesic to block pain signals, a neuromuscular blocker to prevent movement. Each of these drugs is monitored and adjusted continuously by the anesthesiologist, who watches the patient's vital signs on multiple screens and can respond instantly to any change. The patient experiences nothing. One moment they are on the operating table, being told to count backward from 10. The next moment they are in the recovery room, hours later, with the surgery completed. It is as if time has been erased. This is the ideal DWale promised, but could not deliver, a complete elimination of the experience of surgery. But even modern anesthesia has echoes of DWale's problems. There is still the risk of respiratory depression, especially with opioids. There is still the need to find the right balance of drugs, enough to keep the patient unconscious, but not so much that they die. There is still the phenomenon of awareness under anesthesia, where a patient appears unconscious, but is actually awake and paralyzed, able to feel everything, but unable to move or communicate. This is rare, perhaps 1 in 1,000 surgeries, but happens. And it is as terrifying as any nightmare from the medieval period. There is also the issue of postoperative pain management. After surgery, patients are often prescribed opioids. These are effective, but they are addictive. The opioid epidemic that has ravaged the United States and other countries in recent decades has been fueled in part by overprescription of pain medications after surgery. We have come full circle, using the same substance, opium and its modern derivatives, that was in DWale, and facing the same problems of addiction and overdose. So the history of anesthesia is not a simple story of progress from ignorance to enlightenment. It is a story of trial and error, of repeated attempts to solve the same fundamental problem: how to eliminate pain while preserving life. DWale was one such attempt. Modern anesthesia is another, and the quest continues. Researchers today are looking for even better anesthetics, drugs that induce unconsciousness without respiratory depression, that can be reversed instantly, that have no risk of addiction. There's also research into regional anesthesia, blocking nerves locally rather than inducing unconsciousness globally. And there is research into the brain itself, trying to understand at a fundamental level how consciousness arises and how it can be safely suppressed. Each of these modern research programs is, in a sense, a continuation of what the medieval herbalists were trying to do when they mixed opium, henbane, and hemlock into wine and offered it to a patient about to be cut. The goal has always been the same: to make surgery bearable, to spare the patient the full horror of the knife. DWale failed more often than it succeeded. But it tried, and in trying, it taught lessons that we still use. The principle of combining drugs for synergistic effect, the importance of dosing, the need to monitor the patient, the recognition that eliminating pain is worth some risk. These lessons, learned at terrible cost over centuries, are the foundation of modern pain management. DWale is part of that foundation, and for that, it deserves to be remembered. Conclusion and reflection. We have come to the end of our journey through the history of DWale, the medieval anesthetic that put nights to sleep. We have seen what it was made of, how it worked when it worked, why it so often failed, and why it eventually disappeared. We have met the ingredients, each one a deadly poison. We have met the practitioners, housewives and monks and barber surgeons, who took terrible risks to spare others pain. And we have seen the broader context, the brutal world of medieval surgery, where DWale was not just a medical curiosity, but a desperate necessity. What can we say at the end about this strange and dangerous concoction? First, that it was real. DWale was not legend. It was not folklore exaggerated by time. It was an actual medical preparation, recorded in dozens of manuscripts, actually used by real people on real patients. The recipes survive. The literary references survive. The archaeological traces survive. Second, that it represented genuine medical innovation. The people who developed DWale were not foolish or superstitious. They were observant, practical, and willing to experiment. They recognized that certain plants could change consciousness. They tested combinations. They recorded what worked and what did not. This is empirical science, even if it lacked the theoretical framework we have today. Third, that it was extraordinarily dangerous. The line between an effective dose and a lethal dose was so thin as to be almost non-existent. Every use of DWale was a gamble, and the stakes were life itself. Many patients who drank DWale never woke up. Others woke changed, their minds damaged. The risks were known and accepted because the alternative, conscious surgery, was unthinkable. Fourth, that it mattered. For the patients who underwent surgery with the help of DWale, for the families who administered it, for the communities where it was used, DWale was important. It offered hope. It offered the possibility of mercy in a merciless world. Even if it failed half the time, even if it killed as often as it cured, it was better than nothing. And finally, that DWale is part of our history. It is part of the long story of humanity's struggle against pain. From the ancient Greeks soaking sponges in opium to the modern anesthesiologist adjusting a flow of sevoflurane, we have always sought to make surgery survivable, to remove the barrier of pain that stands between the patient and healing. DWale was a step on that path. A small step, a stumbling step, a step taken in darkness with no clear sense of where it led. But a step nonetheless. Today, we live in a world where anesthesia is routine, where pain management is sophisticated, where surgery is performed on a scale and with a success rate that would have seemed miraculous to our medieval ancestors. We can repair hearts, transplant organs, remove tumors from the brain, all while the patient sleeps peacefully. This is an extraordinary achievement, but it is built on centuries of experimentation, of failure, of learning from mistakes made on living patients who had no choice but to trust in remedies that were only partly understood. DWale was part of that learning process. The people who used it were pioneers, in their own way, even if their tools were crude and their understanding incomplete. They deserve to be remembered not with condescension, but with respect. They faced the problem of pain, the oldest and most fundamental problem in medicine, and they tried to solve it. They failed more often than they succeeded, but they tried. And in trying, they moved us, however incrementally, toward the world we live in now. A world where surgery does not have to be torture, where pain can be eliminated, where we can, for a time, escape from consciousness itself and return unharmed. This is the legacy of DWale, not the recipes themselves, which are obsolete and should never be used, but the idea behind them. The refusal to accept pain as inevitable. The determination to find a way to make healing less brutal. That determination persists. Every advance in anesthesia, every new pain medication, every improvement in surgical technique is a continuation of what began thousands of years ago with the opium poppy and the mandrake root and the medieval housewife mixing a deadly drink in the desperate hope of sparing someone she loved. The story is not finished. Pain remains. Addiction remains. The search for better, safer ways to manage both continues. We have come far, but there is farther to go. And as we go forward, it is worth looking back, occasionally, to where we have been, to the remedies that failed, to the risks that were taken, to the people who tried, even when the odds were against them, to DWale, the medieval anesthetic that put nights to sleep. A failure by modern standards, a tragedy in many individual cases, but also a monument to human ingenuity, to compassion, and to the enduring hope that we can make the world a little less painful than we found it. If you've made it this far through our journey into the dark history of DWale, I want to thank you. This is the kind of deep historical research that takes time to create, and your attention means everything. If you found this fascinating or educational, or if it gave you a new perspective on medieval medicine and the origins of modern anesthesia, please consider liking this video and subscribing to the channel. Your support allows me to keep creating these long-form historical documentaries. And let me know in the comments, where are you watching from? What time is it for you right now? And what aspect of DWale's history surprised you most? I love hearing from viewers around the world. Until next time, rest well, and be grateful that if you ever need surgery, you won't need DWale.